activities. Good morning, Federica.
Yes, nice to meet you.
Yeah, that's right. Okay.
I think we can start with the first speaker of this morning, Dr. Gianluca Sambataro, who is going to present us the current knowledge on interstitial pneumonia with autoimmune features. A very, very challenging team with a lot of questions.
That is interstitial pneumonia with autoimmune feature. The definition of IPAF is a research classification aimed to include ILD patients with some clinical feature resembling autoimmune diseases, but not sufficient to reach specific classification criteria. This is a very common clinical picture in a pneumologic unit, and before the IPAF criteria, we had at least 4 sets of different criteria for this condition until 2015, in which ERS and the ATS endorsed a joint effort, including rheumatologists, pathologists, and radiologists, to propose the classification criteria of IPAF. IPAF, for the classification, required the presence of an idiopathic interstitial pneumonia with at least 1 item from 2 different domains, from the clinical domain, in which can include the most common feature of autoimmune diseases, the serological domain, about all the autoantibodies are included, and above all, the morphological domain, in which all the possible radiological and histological pattern of ILD are present, even the presence of only bronchiectasis, with the exception of UAP pattern that was considered not sufficiently associated with the definition, with the diagnosis of connective tissue disease to be included. So, the morphological domain have the aim to make harder the classification of UAP patients as IPAF, requiring at least 1 item from the clinical and the serological domain. Why IPAF classification is actually useful? For 2 reasons. The first is that ILD could be the first, the main, or even the sole clinical manifestation of connective tissue disease. This is an example from a study of Lorenzo, in which ILD, isolated ILD, is the only manifestation in antisynthesis syndrome at the first visit in about 40% of antisynthesis patients, but remain the sole clinical manifestation also in a significant proportion of antisynthesis patients. I would highlight the proportion in anti-PL12 positivity, that is 40% at the last follow-up. Moreover, the clinical presentation of patients could be also associated to the unit in which the person refers, because in rheumatology unit, patients had a florid clinical picture from the autoimmune point of view, but generally a mild clinical presentation of the lung involvement. On the contrary, in pulmonary units, the diagnosis made of CTD ILD generally have a significant impairment of the lung function, but a nuanced autoimmune feature. Also, we can note that taking into account only patients enrolled as a CTD-ILD in a respiratory unit, the most common radiological pattern is UAP, even in systemic sclerosis. So it is totally the opposite of our experience in a rheumatologic unit. What kind of patients were included in IPAF classification? We have 3 main subset of patients. First of all, the stochastic association, because it's clear that given that 3–5% of general population can have renal phenomenon, we can assume that 5% of chronically hypersensitive pneumonia patients could have Raynaud phenomenon not associated with the ILD. Moreover, IPAF could include patients in which ILD is the first manifestation with other autoimmune features that can be developed during the follow-up, or including an incomplete form in which ILD could remain the sole clinical manifestation. A retrospective study on IPAF were very show a very great heterogeneity in the impact of clinical feature or serological feature. This heterogeneity was mitigated in the prospective study, although any difference are present probably due to the specific expertise of each center. The question is if IPAF criteria actually works. To consider a possible gold standard to define the utility of IPAF criteria, we consider the possible evolution from an undifferentiated form to a definite autoimmune disease. This question was assessed by 3 different monocentric cohorts, proving a progression towards autoimmune disease in 28% of the patients in a mean time of 2 years. To assess this question, we conducted a multi-center longitudinal prospective study involving centers with an established close collaboration between pulmonologists and rheumatologists. We enrolled 191 patients through 95 different combinations of IPAF criteria, in which the most common is clearly the minimum of 2 items, but patients showed also up to 6 different criteria together. The progression towards autoimmune disease is of 24% of patients in a meantime of 2 years without any association with the presence of a single item or a combination of domains. So the question is the prognosis of IPAF patients. The prognosis seems to be better than IPF as expected, but worse than a CTD. For in a group of idiopathic ILD patients, IPAF seems to be a good classification, but it's expected that considering that the most common ILD, idiopathic ILD is IPF. Some authors reported the possibility that IPAF could be a stable disease, but it could be not. The prognosis obviously associated with the pattern of ILD. And the UAP pattern show a great impairment of lung functions. The prognosis of IPAF UAP patients are totally similar to IPF, whereas non-UAP IPAF perform in a way very similar to CTD ILD. From our point of view, in our prospective cohort, we noted that about 40% of patients required oxygen support and 20% within 3 months from the first visit associated with the ANA positivity and smoking habit. A progressive fibrosing phenotype was not in 35% of patients. Respiratory deaths were 7% associated with the presence of Raynaud phenomenon of NSIAP plus OP pattern. A very interesting question is how to treat IPAF patients. So, in this first study, also controlling for the presence of UAP radiographic pattern, the association of mycophenolate and prednisone during the first year was associated with no progression. Is totally not in line with what reported for IPF, for example. Also in this study, we noted a protective effect even by the use of steroids in the UAP pattern. And this is a very interesting study by Yasuhiko Yamano, in which the histological UAP IPAF improved with the treatment with immunosuppressant. In a sub-analysis, the authors noted that the response to immunosuppressive drugs was associated with the presence of a significant proportion of inflammatory cells among a UAP pattern, as expected. So, Another question on IPAF criteria could be if IPAF criteria can be improved. This is a summary of the last study on UCTD patients in which I reported the rate of progression towards specific autoimmune diseases. IPAF is about 25%. The first study with this aim was published by Graham et al. That reported that IPAF positive patients positive for mucin-specific antibodies perform in a way totally similar to what reported for antisynthetase and dermatomyositis. But is our experience probably if we have patients with ILD and the positivity for a specific autoimmune specific antisynthetase antibody, we can make a diagnosis of antisynthetase syndrome. From our point of view, we questioned the presence of the morphological domain because UAP pattern is the most common radiological pattern in rheumatoid arthritis, interstitial lung disease, and also in the at least long-standing systemic sclerosis. So we tried to exclude the morphological domain and enroll UAP patients as associated with the presence of only one domain from the clinical serological ones. We called for a joke this group usual interstitial pneumonia with autoimmune feature, UEPAF. So usual interstitial pneumonia with autoimmune feature had proved to have similar feature of classic IPAF, a greater rate of progression towards autoimmune diseases than a classic IPF, and a rate of progression similar to what reported for the classic IPAF. So a possible modification on IPAF criteria could be the removal of morphological domain and the exclusion also of autoantibodies and clinical feature highly specific for a specific condition, such as pitting scars, ulcers, or Gottron papulus. Other possible new items could be the Zika syndrome, myalgia, naval capillaroscopy findings. Very interesting to include that. We would highlight the role of rheumatologists working together with pulmonologists for ILD patients, showing an early highly treated manuscript on IPAF in which a diagnosis of primary Sjögren's syndrome was not made even with the presence of classical histological inflammation of the salivary glands with the Zika syndrome, or a diagnosis of systemic sclerosis was not made in patients with ILD, renal phenomenon, and positive nine-fold video capillaroscopy, even with the positivity for specific autoantibodies. So I can also highlight that, in my opinion, 9 different criteria of IPAF cannot be together without a specific diagnosis. But the collaboration between rheumatologists and pulmonologists probably started very early. This is totally my opinion. I cannot have any established data on this slide, but I make a question regarding the difference between the study of demens and the Panther study. Why? In these two studies, including the same patients with the same pulmonary function and the same treatment, in the first study, we have improvement of ILD patients, IPF in this case. In the second study, published in the same journal, we had a very great detrimental effect. So why this one? Because probably because in the 2010 we updated the criteria for rheumatoid arthritis, including anti-citrullinated protein antibody. So we improved the diagnosis of rheumatoid arthritis and created a more homogeneous group of IPF patients in the Panther study. And the response to the triplotherapy probably is due of the enrollment in the demens study of occult form of rheumatoid arthritis interstitial lung disease. In conclusion, IPAF is a research classification, not a diagnosis, resembling UCTD-ILD. The criteria included a group of ILD with a significant likelihood to develop a specific autoimmune disease. The prognosis is better than IPF, but worse than CTD-ILD. Immunosuppression could be useful also in UAP patients, and the current criteria could be improved. Thank you.
Thank you very much, Luca. And I think the discussion will be very, very busy at the end of the session. Thank you.
Very nice slide. What is the world without rheumatologist? Very nice. Okay.
But he's working as a rheumatologist and pneumologist in the same person, so I think.
Yeah, two worlds together.
So, shall I introduce the next speaker, who's Professor Mariella Gatto from the University of Turin, right? Okay, who's going to speak about myositis-related disorders in lung, clinical aspects and screening. Thank you.
Thank you so much. Yes, thank you so much. I'm very glad to be here. Thanks to the organizer for the invitation. So I'm trying to go quickly through my agenda. So the topic is, of course, challenging, and I try to cover that in the next few minutes. So the background. So we heard a lot from yesterday to today. So how important lung involvement is in myositis, idiopathic myositis. So of course, we're going to focus basically on the interstitial lung disease side, but I just wanted you to just remind or remember that there are many other sort of involvement that may occur in idiopathic myositis. We do not have time to cover all of those, and the center of the talk would be indeed the interstitial inflammation, the interstitial lung disease. For maybe, I would say, the younger fellows here, I just would like to remind you that the interstitium is a very important structure in the lung, starting from the respiratory bronchi and changing histologically and functionally towards the final end of the alveoli. So the inflammatory process here is mostly involving the tiny interstitium between the alveolus and the capillaries, but you have to bear in mind that inflammation is involving the triad, so the alveolus, the capillary, and the space in between. So the most probably appropriate term for defining that is that we are dealing with a diffuse parenchymal lung disease, which is indeed involving the whole respiratory exchange surface. As such, the exposition and the interaction between the wide interstitium and the external environment may be involved in triggering the breach of tolerance, which is taking place in the lung, and then likely involved in the breach of systemic tolerance in myositis. So I like this picture because it kind of recalls what we are used to think of in rheumatoid arthritis. So loss of tolerance occurring in the lung before involving the joints, and this might be possible, this might be the case, at least in some subsets of inflammatory myositis, where JO, so the histidyl RNA synthetase, was found to be hyperexpressed in the epithelial, in the lungs, and in the regenerating muscle fibers, but not in the healthy muscle. So a cross-reactivity is possible. And also a peculiar isoform of JO, which is particularly prone to cleavage by granzyme B, is found in the lung, which may generate neoepitopes through the continuous cleavage in the lung indeed. So just now to move forward to the clinical side of our talk, I'm presenting here some data from the Padova cohort, where I've been working for many years. So in line with the data from the literature, half of our patients did have pulmonary involvement. So you see the blue side, and which kind of involvement was that? Very importantly, it could be one of the first manifestations, so present a diagnosis of myositis, and in line with the literature, the predominant pattern was indeed an SIP, followed by inflammatory organizing pneumonia. And the patients who were more prone to present inflammatory lung disease, interstitial lung disease, were belonging to antisynthetase, the antisynthetase group, followed by dermatomyositis. We did have a predominance of antisynthetase antibodies. You can see that on the right, followed by anti-Rho52 alone or in combination, and others in MDA5. There could be actually some loss of the MDA5 antibodies here because maybe they were not collected on time in very severe patients. So it might be slightly higher. And this is important that we found this symptom at the very beginning, as shown in other cohorts. It is a work from Professor Cavagna. You can see that ILD can be present at onset as the only item of interstitial in idiopathic myositis in 1/4 of the patients. And it is indeed the most frequent manifestations that occurs throughout the follow-up, especially in patients who bear a peculiar autoantibody arrangement, among which antisynthetase antibodies and especially non-JO seem to be associated with a higher ILD predominance. Moving to the details of the patterns that we are facing, I try to summarize that in some pictures. So along this line, you see that on one side, we might sort of delineate the most inflammatory patterns with endothelial activation and with a patchy distribution, while on the other side, we do have the fibrosing, very severely fibrosing phenotype. This is not a timeline. Again, for the younger people, this is not like a linear development from the inflammation to fibrosis. That might be a sort of evolution, but it's not like it's a very definite clinical entities that do have different pathogenesis. But they can combine histologically and clinically in very severe and dramatically evolving phenotypes, which we know and we call rapidly progressive ILD. So where rapidly progressive inflammation and mounting fibrosis do develop very quickly and are together entangled. This is also evident from the histological point of view, where you have inflammatory lesions and replenishment of the distal airways in your left-hand part of the slide, while in an inflammatory infiltrate in the rapidly progressive phenotype, and you do have a distortion of the architecture in the fibrotic phenotype. It's like interesting to see that on the very right side of the picture, you can still see some tiny parts of normal lung tissue. And this is important also clinically, because even though you see like this widespread reticulation, and of course you expect the patient to have dyspnea, shortness of breath, this can be a very late feature because the lung, the healthy lung, is still there and is progressively sort of diminished by the inflammatory process. So on the right side of the picture, you do have a progressive loss of the healthy surface for the gas exchange, while in the left side of the picture, you have this patchy distribution, and you have the black lung that it might seem normal in the CT scan, but actually also in the black section of the CT scan, you do have endothelial activation, you do have damage of the interstitium of the triad that we mentioned before. So you do have inefficacious gas exchange, even though you see the black parenchyma on the CT scan. And therefore, this aligns with the fact that patients with OP and ZIP-OP, even in the face of, let's say, a moderate alteration in the CT scan, they can have dramatic symptoms with rapid onset of cough, shortness of breath, and this can be escalating in days or weeks. While you can have a random retrieval of a fibrotic phenotype at the very right, where patients just take a CT scan and you see the lung is completely invaded by fibrosis, and these patients never had cough in their clinical history. And this is because the NZIP and ZIP-OP is histologically diffuse, even though you don't see that completely on the CT scan. In the middle picture, you do have a very impressive CT scan, and you do have impressive clinical symptoms. So therefore, we call this a discrepancy between the clinical and radiological findings that we might have in clinic. Okay. And if we want to place, let's say, just to label those, our clinical entities along this line, then we might have something more inflammatory in dermatomyositis, antisynthetase, something more fibrotic, as you can see, and very explosive phenotypes that we are normally, but not only, reconciling with MDA5 subsets. Why is it important? Because, of course, any kind of ILD in inflammatory myositis does worsen the prognosis of the patient, especially if you have a rapid phenotype, and that is going to be talked about later. But there are also prognostic factors in non-rapid progressive ILD, which is if you're older, if you do have still an acute pneumonia, if you do have decline in your respiratory parameters and a greater extent of lesions at the CT scan. And the autoantibody arrangement is indeed important because according to the cohorts, but still having a JO does better than having other autoantibody arrangements. It could also be due to an early diagnosis in some cases. And what is also important, if you compare lung involvement in myositis to lung involvement across other CTDs, you can see that the proportion of patients who do have symptoms at some point is higher. And this is actually a chance because it may allow an early detection and it may allow to favorably use a window of opportunity, which is not always the case, for example, in scleroderma. And so how do we identify those patients? Of course, coming back to the initial cohort, there are factors which are associated with ILD presence and development, as we mentioned, autoantibody arrangement, and clinical symptoms that are often related to an antisynthetase syndrome, while it is less likely to happen in very active myositis and skin disease. And this is not just the Padova cohort. These data are also confirmed in a wide meta-analysis collecting more than 800 patients over the literature in the last few years. So it is important to look out for the phenotype, for the autoantibody profile, and importantly, also the inflammatory markers are something that is emerging that we should pay attention to, not only in the rapidly progressive phenotype, but also in what we are used to call antisynthetase or fibrotic fibrosing phenotypes. Of course, this is literature and this is the main path we should go for. Exceptions do exist. This is a patient with a rapidly progressive me-too ILD. So just to say that in the clinic, then exceptions may occur and should be taken care of course. From the muscle to the lung, and then vice versa from the lung to the muscle. We saw what happens. We have a diagnosis of myositis already established, but we could also receive or bump into a patient who does have an isolated ILD, and Gianluca just spoke about this. So there is growing interest in how to screen and why to screen patients for myositis antibodies if they present with ILD only. Well, it's true that it has a clinical weight because nearly 1/4 of the patients might display at least a single positivity for those, and the prevalence increases as long as you consider inflammatory patterns or, of course, patients who did have some other symptoms of CTDs. That's important, not just from a nosologic point of view, but also because it may very much impact the prognosis and the therapeutic approach of these patients. So the question is still hanging, and should then all ILD be tested for myositis antibodies? Well, this is a debated point. The important thing is probably also to perform a test, like every time in medicine, knowing why you are doing that and what this could provide to the approach to your patient. So probably should we test those antibodies in light of changing the therapeutic approach in that patient? Then why? Maybe we should screen patients who do display a more inflammatory, let's say, pattern at the CT scan, because in that case, we know that this might favor the adoption of immunosuppression in face of the only antifibrotic. The combination could also be possible if the fibrotic pattern is present. And what about the prognosis? We just saw that, let's say, IPF-IPAF is still sort of more benign clinical entity than the primitive IPF. And yesterday we heard this morning, we heard that yesterday in the very nice talk from Professor Tomasetti, who showed in a recent data that patients who do have IPF-IPAF, they have a better prognosis than IPF alone. And what is very relevant in this graph is that if you have IPF with an antibody positivity, like Rho52, for example, it doesn't really change the prognosis. So the message is an antibody is not sufficient when matched to a very fibrotic pattern to change the approach to the patient, to change the history of that patient. So the important thing is that we need to be able to give a correct interpretation and a correct, let's say, approach to what we are testing. So not all autoimmune associated serological features do have clinical or therapeutic implications. It might also be the case in clinic that you kind of visit a patient who for some other reason has undergone screening for autoantibodies, and then you have a random retrieval of autoantibody positivity, then everything should be tailored on the single patient. So if there is room for immunosuppression because of IPAF is fulfilled and an inflammatory pattern is present, then it might be considered, but every time it should take into account the criticism that can arise in that single patient. So just very quickly, how do we screen the patient from the instrumental point of view? HRCT is the most sensitive and specific radiological exam to define extent and type of ILD subset. But as you can see in this study, lung ultrasound might be very useful for patient screening because it has a high sensitivity, no radiation, and so it can be used as a useful tool for quick and also accurate screening of our patients with a suspected interstitial lung disease, as a completely negative ultrasound might give us some time and spare some CT scan in the long run. This is a wrap up from Gianluca Sambataro, who showed recently that pulmonary function tests are indeed important, but they are important especially in patient monitoring rather than, of course, as a sole tool for diagnosis. So it's good to have them, it's good to monitor them, and it's useful to follow up patient progression. So just as a final slide, how do we screen our patients for myositis associated interstitial lung disease? So in the case of a definite myositis diagnosis, we should bear in mind that patients with a peculiar autoantibody arrangement do have an increased risk of ILD. And so in those patients, especially in those patients, it's worth going for a deeper screening. On the other hand, in patients with isolated ILD, we should bear in mind that increased risk of myositis is associated with peculiar CD patterns, especially inflammatory, and it is even more likely in patients who do have symptoms or laboratory abnormalities which are not usually associated to, let's say, primitive ILD. Once the screening is done, a sort of, this is, let's say, you don't see any reference here because it's something that it's done in practice, it's not written anywhere, but it's a good idea to also go for bronchoalveolar lavage screening for infections. And as we heard yesterday from Professor Tomasetti, cryobiopsy is something that, at least in some specific patient subset who do have a less inflammatory appearance at the CT scan, might be useful to shape the following treatment. So in conclusion, ILD is frequent and, as we heard, might be the only manifestation of inflammatory myositis. Screening is important, especially in patients who do have a higher a priori test probability to have a CTD and a myositis, and interpretation of what we see and of complex findings is always paramount. Thank you very much.
Thank you. The discussion is at the end of this session. Thank you.
Our next speaker is Professor Rohit Agarwal. He doesn't need any presentation. He's going to talk about myositis-related disorders and lung issues on therapy.
Hello, everybody. Good morning. My name is Rohit Agarwal. I'm a professor of medicine at University of Pittsburgh, USA. First of all, I would like to thank the organizers for inviting me to present this talk today. My topic is myositis-associated ILD, issues on therapy. Before I start, I want to thank the organizers for inviting me to present this talk. I had a pleasure of visiting Pavia, Italy, and Dr. Lorenzo Cavagna was so kind to show me the city. It's a beautiful city, and I'm sure that you're enjoying there. I was there almost a year ago, and I would love to be there again. So with that, I would start my talk. So first of all, when you talk about myositis ILD, we first need to understand what's the overall risk of ILD in myositis. If we take the studies in last couple of decades, what we see overall the risk of ILD in all comers myositis is about 30 to 40%. But what's more important is that ILD is the number one cause of mortality and morbidity in our myositis patients. So that's why the rheumatologists care a lot about ILD, obviously, along with pulmonologists, because myositis, muscle disease or skin disease doesn't kill our patient, but ILD kills our patients. If you look at overall prevalence of myositis ILD among other CTD or connective tissue disease ILD or autoimmune ILD, what you see is that idiopathic inflammatory myopathies or myositis is quite high in prevalence. It's almost near the prevalence of ILD that we see in systemic sclerosis, as per at least this data. And also, when we look into what are the risk factors of myositis ILD, we understand very quickly that certain antibodies, certain myositis-specific antibodies gives us higher risk for myositis-associated ILD as compared to other autoantibodies. Here I'm showing you a Venn diagram which is divided into 4 clinical phenotypes: PM, which is polymyositis; DM, which is dermatomyositis; overlap myositis; and NM, which is necrotizing myopathy. Within each clinical phenotype, you see several serological bubbles, and 3 of the bubbles that are pointed out to you are antisynthetase antibodies, which you very well know. Jo1 and non-Jo1 antisynthetase antibodies gives you high risk for ILD. Anti-MDF5 antibody, which gives you high risk for rapidly progressive ILD, and several overlap antibodies, which also have high risk for ILD. If you look at overall risk of ILD in Jo1 and non-Jo1 is anywhere between 70 to 80%. Non-Jo1 has a higher risk than Jo1 antibodies for ILD. If you look at anti-MDF5 antibody, in Western world, we see the risk is around 40 to 50% of ILD. So almost half the patient gets ILD and half do not. But if you look at the Asian literature, or Southeast Asia, China, Japan, and other areas, you see the frequency of ILD is quite high. In those patient population, and it's in those ethnicities, it's much more than 50%. And the third antibody, I always put people that when you have ILD, also think about overlap antibodies, which is PMSCL, COO, U1RNP, and Rho antibody. In terms of pattern of ILD, now, before we dive into the treatment, pharmacological treatment, we also need to understand what are the different patterns of ILD in myositis ILD. And I'm fortunate to work with myositis ILD because it has almost all patterns of pathology that we see in ILD, which includes UIP, NSIP being the most common, but we also fairly commonly see OP and other patterns as well. So almost all major patterns of interstitial lung disease are represented in myositis ILD. Before we again dive into the treatment, we will talk about treatment in 2 different patterns. One is a pattern of rapidly progressive ILD, which is generally associated with anti-MDF5 antibody, but could be seen in other autoantibodies in myositis. I have certainly seen cases of antisynthetase and other antibodies with rapidly progressive ILD. But most commonly, you will associate rapidly progressive ILD with anti-MDF5. And I've shown you a survival curve of anti-MDF5 positive antibody, how quickly they die within the first year, about 30 to 35% mortality. And on the other hand, we see chronic ILD, in many cases of chronic progressive ILD, which is represented typically by anti-synthetase antibody or overlap antibodies, and they have a nice step-down curve for survival. And also, let's talk about why is early diagnosis and management important. And I think this graph really, drives home the point that once the patient reaches acute respiratory failure leading to ICU admission, overall survival is very poor. Even in anti-synthetase antibody, which is somewhat more responsive to treatment, the survival is about 70% after you've been admitted to ICU. And anti-MDF5 antibody, the survival is really poor. About 80 to 90% of those patients would die. So that's why early diagnosis management is important in myositis ILD, because by the time the patient reaches ICU, it's kind of a done game. And also, I wanted to point out that almost 40% patients in myositis ILD may have no extrapulmonary features at presentation. And then in terms of treatment, whatever treatment I'm going to talk about, I want to point out that they are based on case reports, case series, maybe retrospective controlled studies, and maybe some prospective open label studies. But we don't have any major randomized controlled trial in myositis ILD. And the article I will quote is this article where they did a very nice systematic review and meta-analysis of almost 200 plus, 300 plus patients, multiple studies, but very few of them were prospective. So start with both in progressive ILD as well as rapidly progressive ILD, one of the mainstay of treatment is still steroid. We haven't gotten rid of steroids. We still need to give steroids in quite a high doses. Sometimes we have to give IV steroid, pulse steroid, and definitely at least 1 milligram per kilogram steroid for at least initial period. The challenge with steroid, obviously, is that when we taper the steroid beyond 20 milligram or 10 milligram, the disease tends to flare. Plus, we have a significant issues with steroid toxicity over months of treatment of high doses of steroid. So we want to get away from steroid, but currently we still have to use quite a lot of steroids. The second drug is mycophenolate, and we use quite a lot of mycophenolate specifically in patients with progressive ILD. It's almost becoming a first line in MAILD. MAILD is myositis-associated ILD. And many retrospective studies of around 20 to 40 patients have shown that initiation of mycophenolate has led to improvement in forced vital capacity and also led to significant reduction in the steroid dosing in the patients. So I went in the wrong direction. Another drug that I always like to talk about is tacrolimus. Increasing evidence suggests that tacrolimus is really efficacious in myositis ILD. I'm quoting two studies, one from our centers where we treated 13 refractory patients with anti-synthetase antibodies, which has already failed true treatment plus steroid in past. And when we initiated tacrolimus on those patients, they clearly improved in their forced vital capacity. But also, we have seen survival outcomes from retrospective control studies, which show that tacrolimus, early tacrolimus plus steroid is superior to a step-up therapy or other treatments. What about rituximab in progressive ILD? Multiple case series, mostly retrospective, mostly around 20 to 40 patients, 50 patients suggest that there is significant improvement in forced vital capacity once we initiate rituximab in patients with myositis ILD. And data from our center from the rituximab in myositis trial, which was a myositis trial of 200 patients, also suggests that rituximab works fairly well on patients who have anti-synthetase antibody or generally who are antibody positive associated with myositis. And this is the data that I was talking about. This is a RIM study in which on the x-axis you see times in weeks, and y-axis you see probability of not improving. And Jo1 antibody and Mi2 antibody, which is represented by red and black lines, had the best outcome in once the patient received rituximab, whereas the patient who did not have any myositis antibody had the worst outcome as compared to the patients with JO1 or MI2. So we prefer rituximab in patients with antisynthetase syndrome ILD. What about cyclophosphamide? Again, multiple prospective studies, actually a couple of prospective studies and multiple retrospective studies have shown that initiation of cyclophosphamide actually lead to significant improvement in myositis-associated ILD, shown in this figure by FVC as well as CT scan score that forced vital capacity and vital capacity increases, whereas CT score decreases after initiation of cyclophosphamide. Now, so far we have talked about progressive ILD or chronic progressive ILD. What about rapidly progressive ILD? Now, rapidly progressive ILD is somewhat different animal. First, let's talk about what is rapidly progressive ILD. Rapidly progressive ILD typically means from the onset of dyspnea or cough to requirement of oxygen, hospitalization, or mechanical ventilation or death is within 3 months. It is highly associated with anti-MDA5 antibody as well as clinically myopathic DM. The response, the outcome that we think is a good outcome is really survival at 3 months. See, when we're talking about chronic progressive ILD, we're talking about improvement in FVC. We're talking about improvement in CT scan. But when we're talking about outcomes in rapidly progressive ILD, we're talking about survival. It's survival at 3 months, 6 months, 12 months. So that's how bad this disease is. Now, multiple studies have suggested that combination immune suppression is superior to a single or step-up treatment for patients with anti-MDA5 antibody or rapidly progressive ILD. As shown in this survival curve here, when the patient was given high-dose glucocorticoid along with tacrolimus and along with IV cyclophosphamide early on or combination therapy from the beginning, they had much better outcomes, at least in terms of survival, as compared to historical controls of step-up immune suppressive therapy in past. And that's a very strong data. I always believe survival outcomes don't lie. What about rituximab, the role of rituximab in rapidly progressive ILD, specifically patient with anti-MDA5? Again, the data is very little, but retrospective control study suggested when the rituximab was given to the patient with rapidly progressive ILD as compared to the groups where cyclophosphamide was given or groups where neither cyclophosphamide or nor rituximab was given, rituximab was numerically better in patients as compared to other groups. Obviously, very small numbers, so the p-value would not be significant, but again suggests, at least from the study, that rituximab probably has some role to do in rapidly progressive ILD. What about IVIG? So IVIG, as you know, is being used for myositis and dermatomyositis all the time. But what about IVIG in rapidly progressive ILD? This study, again, retrospective in nature and compared to other treatment, IVIG group, which was around n is equal to 21, as compared to non-IVIG group, n is equal to 17, IVIG was superior to non-IVIG group. However, any of these retrospective control studies have a lot of bias by indication. Plasmapheresis, again, multiple small case series and studies have shown that plasmapheresis early on in patients with rapidly progressive ILD and anti-MDA5 antibody is superior to when the plasmapheresis was not initiated. Again, marred with the problems of biases in a retrospective study. The new kid on the block is tofacitinib. Very nice article at NEJM showed that when we initiate tofacitinib in clinically myopathic DM and ILD, anti-MDA5 antibody patient, 18 patient, they had 100% survival, which is unheard of, at least in my center and other studies that I have seen, that 100% survival of all 18 patients when the treatment of tofacitinib, which is a JAK kinase inhibitor, was initiated in patients with anti-MDA5 antibody body positive rapidly progressive ILD. Although most patients were also on steroid, and when we compare it to historical control, we see the survival rates are around 70 to 80% in 6 months as compared to 100% in tofacitinib. Not only that, FVC improved as well. What about ECMO? ECMO is typically well tolerated in patients with myositis rapidly progressive ILD. That's not a problem. The problem with ECMO is if you don't have a plan to transition the patient from ECMO to lung transplantation, the outcome's going to be not very good, because ECMO is not the end product. the end product should be the lung transplantation. In this study, 8 out of 9 patients who were put on ECMO died, but they died mainly because they were not offered lung transplantation. Only one died due to sepsis. So that suggests when we put patients on ECMO, we should at least have a plan for them to transition them to lung transplantation. Also, we recognize anti-MDF5 antibody and clinical phenotype of clinically myopathic DM with significant rashes, specifically palmar papules and some cutaneous ulceration and severe rashes. However, I want to remind our pulmonologists that not all patients read books, and some patients can have rapidly progressive ILD with anti-MDF5 antibody without any evidence of rash or clinical features of myositis. You still should evaluate those patients with anti-MDF5 antibodies. Now, in last few minutes, I want to talk about nintedanib. Has been an approved treatment for progressive fibrosing interstitial lung disease with significant results showing improvement in FVC changes over time. What about nintedanib in myositis-associated ILD? So far, we have very few studies on this topic. However, the studies that I'm going to quote suggest that perhaps we should be using nintedanib in myositis ILD, or at least in some cases for sure. In this study, what they did is they took the patients and gave nintedanib to some patients, and they compared them to the patients who did not get nintedanib. So around 36 patients got nintedanib, and they were compared to previous or patients who did not get nintedanib, 115 patients. And they showed survival benefit over long period of time, which is very remarkable because typically survival benefit is very difficult to show. And even when they match the patient with propensity matching with the severity at onset, even then they had survival benefit. And overall, a regression analysis suggests that nintedanib, anti-MDF5 and disease activity was associated with survival, where nintedanib was associated with better survival, whereas high disease activity and anti-MDF5 antibody positivity was associated with worse survival. In the end, I want to talk about the treatment paradigm of chronic progressive ILD. I have here two paradigms, mild to moderate disease and severe progressive ILD. In severe progressive ILD, we typically go for rituximab or cyclophosphamide plus minus IVIG. In occasionally or very severe cases, we may combine rituximab with cyclophosphamide. Whereas in mild to moderate cases, we just go with steroids. Also, nevertheless, in severe, we also give pulse steroid. Once they have taken their initial induction treatment, we have to transition them to first or second line maintenance therapy, which is typically mycophenolate or tacrolimus. And if they fail that, then we go for combination therapies such as cyclophosphamide plus tacrolimus, rituximab plus cyclophosphamide, mycophenolate plus tacrolimus, or ECMO, tofacitinib, nintedanib, and abiracept. Now, with that, I want to also talk about that the need of randomized controlled trial in patients with myositis-associated ILD. We did a first randomized controlled trial using abiracept in antisynthetase ILD, and I'm happy to report that the results are going to be presented very soon. And we actually presented some initial results in EULAR last year with not so much positive results at week 24, but significant trends at week 48 period. In this study, half the patient got abiracept on the top of standard of care immune suppression and half got placebo on the top of standard of care immune suppression, followed by every patient got standard of care immune suppression plus abiracept for next 24 weeks. Last but not the least, I want to talk about the MINT trial. This is a myositis ILD nintedanib trial. This is first fully decentralized ILD randomized clinical trial. In this trial, patient will participate in the study, in the whole study from the comfort of their home, because we have a fully operational decentralized model where we will be recruiting and screening patients from anywhere in US, evaluating their medical record, talking to their doctor, doing the home drug delivery, doing all remote data monitoring using PROs, physical activity monitor, pulse oximetry, blood pressure and heart rate monitoring, home spirometry, telemedicine, and so on, with some in-clinic imaging such as CT scan, PFT near patient's home, and blood collection through nurse going to patient's home. All of that will be then sent to University of Pittsburgh secure server along with specimen collection. So in conclusion, I would recommend that we try to recognize myositis ILD early and at-risk patient using myositis antibodies. Remember anti-synthetase, anti-MDA5 and overlap antibodies. Try to differentiate early on, is it chronic progressive ILD or rapidly progressive ILD, because treatment may be very different. Many current and novel treatment options are available, but no established data-driven approaches or guidelines are available. We have no randomized clinical trials to guide us. That requires that we need to get together and do more randomized studies. And the role of antifibrotic in myositis ILD needs further evaluation. With that, I would like to thank everyone for listening, and I'll be happy to entertain any questions or feedback through email. Thank you.
Thank you very much. Our next speaker is Albert Selva. He's going to talk about rapidly progressive interstitial lung disease in anti-MDA5 syndrome. Please welcome Professor Albert.
So good morning. Sorry. I am going to talk about the rapidly progressive ILD in those patients with dermatomyositis and anti-MDA5 syndrome. But first of all, I would like to thank the organizers and especially to Lorenzo Cabaña, my friend Lorenzo, for inviting me to participate in this international meeting on interstitial lung disease in rheumatic disorders. I have divided my presentation in 5 parts, each one with a question. I'll try to answer the question or at least to share with you my thoughts. These are my disclosures. The first question is which patients with antibodies anti-MD5 will develop a RP-ILD. So it's an important point. Just a little bit history about the antibody. It was reported or identified by Professor Sato in 2005, and afterwards they find by immunoprecipitation a protein of 140 kilodaltons, and afterwards was identified as anti-MDA5 protein. So the very same year, in 2005, we reported our experience about interstitial lung disease in patients with myositis from our own cohort. And we identified, as you can see here, these different 5 patients who were very homogeneous population. All of them were dermatomyositis, hypomyopathic, with anti-synthetase antibodies negative, and also with a rapidly progressive ILD. So some years after, we analyzed it in the sera collected at this moment, and all of them were anti-MDA5 positive. But come back to the first question, and I would like to highlight some issues from the medical bibliography that has been published the last decade. And what we have learned about the anti-MDA5 syndrome, some issues are important, as we know that we have to be aware about the follow-up the first 1-2 months. We also know that in some studies there is a seasonal spring pattern, and also older people are more prone to develop this severe form of ILD. We also have learned that juvenile forms, unfortunately very rare, but may develop this catastrophic syndrome. What do we do in our clinical practice when we see a patient with anti-MD5, diagnose a patient with anti-MD5 positive antibodies? And neurologists say that brain is time, but we can say that lung is time, because it's very important, a close follow-up of these patients. We usually rely on clinical grounds. You know, dyspnea, the patient complains with dyspnea, inspiratory crackles, and also mechanics hands, which seems to be a marker of this rapidly progressive interstitial lung disease in those patients with anti-MD5. We usually also perform pulmonary function test and high-resolution CT scan in every patient. And if we found any type of ILD in these MD5 positive patients, we immediately begin to treat with immunosuppressive agents, mainly tacrolimus and corticosteroids. We not always perform fibrobronchoscopy or lung biopsy, and usually don't do that. Of course, it depends on the patient. This is a study that was reported by the group from Paris. It's interesting because they analyzed these 121 patients with anti-MDA5, and they were able to identify different clusters. From a clinical point of view, you can say that if the patient is with a bad condition, general condition, mechanical hands, a myopathic form, and dyspnea, probably is in the cluster number 1. It means that is developing a rapidly progressive ILD. On the other hand, this necrotic skin necrosis and skin vasculopathy, those patients with anti-MD5 and these skin lesions are less prone to develop a rapidly progressive interstitial lung disease. So this is an algorithm of what we do in our clinical practice. As I said before, we, from clinical grounds, we identify a patient with dermatomyositis and positive to anti-MDA5. We perform a high-resolution CT scan, pulmonary function test, and oxygen saturation. And if there is, we are able to do the diagnosis of ILD, we have to be aware about the rapidly progressive form. It means that during the first months, the progressive dyspnea, ground glass opacities, and hypoxemia develop. And in these cases, we start immediately the treatment. If there is not rapidly progressive criteria, and there is ILD, we usually treat these patients as conventional antisynthetase syndrome, and we are aware about the outcome of the patient that may change our approach. We usually use corticosteroids and tacrolimus. If there is any contraindication to tacrolimus, we change to mycophenolate. Then, as a summary, we know some clinical factors. There are dyspnea, constitutional symptoms, environmental factors, mechanics, hands, fever, and also spring seasonal pattern and older patients that favor those phenotype of rapidly progressive ILD. On the other hand, juvenile forms, although possible to develop a rapidly progressive ILD, is more rare, and arthritis and skin necrosis also goes against this phenotype, this severe phenotype. And what about the biological parameters? We know that the titer of anti-MDA5 antibodies, we remember yesterday we were talking about the ELISA or the blood, we are able to quantify the titer. It's important because it's a good marker of the risk to develop this RP-ILD. Also, the coexistence of anti-Rho52 and several interleukins, mainly interleukin 1, 6, and recently have been published interleukin 15, seems to be good markers of this unpleasant situation that is RP-ILD. Of course, ferritin, which is very easy to determine, is also helps to the clinician to think about this severe form. So let's move on to the second question. The second question is focused on the pathogenesis. It's a very complex issue. Lorenzo explained yesterday about that, some important issues. We know that there are different studies on the pipeline, and we must wait about the results. But as a general idea, we know that probably an external agent, mainly virus, could be tumoral antigens or could be other issues, may interact with the MDA5 in cytoplasmic. It's cytoplasmic sensor, especially to the virus, and activate the interferon-1 pathway, and afterwards the JAK-STAT pathway and autoimmune disease and inflammation. So it's here because it's so important to try to, in the refractory cases, to treat with JAK inhibitors. I am talking about the tofacitinib. So go to the next question, that which would be the first or the best therapeutic approach in these patients? We agree with Roy that triple therapy, combination therapy is the first option, but we usually use glucocorticosteroids and an and calcineurin antagonists, we no use usually cyclophosphamide. So we can compare corticosteroids plus calcineurin inhibitors, or adding or not cyclophosphamide. So if there is some type of refractority to the treatment, then we add other options, other therapeutic options, which include intravenous immunoglobulin, plasmapheresis, which is a very useful and very important strategy, and also polymyxin B chemoperfusion. And the last step is the ECMO just before possible lung transplantation. Important issue is that from the very onset, we refer the patient with this severe condition to our colleagues from the lung transplantation unit just to be evaluated. You can see here, you can see here the our therapeutical options in the rapidly progressive ILDs. Recently, we have introduced the tofacitinib because we think that it's an important option to take into account. This is a strategy for treat RP-ILD from the Managing Myositis book. It's an editor, our colleague Freud. And you can see that here is not included tofacitinib. Probably it will change in the future, in the next strategies or the next reviews, because I think it's a good therapeutic option. We know that CAR T cells have been used in patients with antisynthetase syndrome, so we must be aware about this possibility. Of course, we have not experience about that, and we are not aware that any case has been reported. But I think that in the future, some cases will be reported focused on this type of therapy. And considering antifibrotic agents, we only use these drugs in those patients with who had survival the acute situation and develop a progressive fibrosing ILD. It's clear that we can use these antifibrotic agents, but we are not convinced to use from the very onset. These are the two papers that published about this issue, and the study that includes pirfenidone didn't find any difference with the controls, and the other study that includes nintedanib, those patients, it's a retrospective study. I was not convinced by the results. I agree with Roy that we need further studies before to use from the very onset antifibrotic agents. So the fourth question is, which is or should be the role of ECMO? We were talking about ECMO all the time. It's a very useful technique in those patients. And if you have a look to the bibliography, you can see that most of patients died. But we have to keep in mind that ECMO is not a therapeutic tool. It's just a tool to win or to buy some time, or in order to go to lung transplantation, or in order to decide which will be the best treatment for this patient. And this is the last patient that we have had in our hospital in last summer in June with an intensive care unit. And he was, you can see here, he was receiving ECMO. He was not doing well. He needed hemoperfusion, plasmapheresis, tacrolimus, intravenous immunoglobulin, and we have to decide lung transplantation versus add another immunosuppressive agent, in this case, tofacitinib. And we have to discuss that with our colleagues from pneumology and our colleagues from intensive unit care. So we need time to think about that, and ECMO gives us this time. In this case, we added tofacitinib, and this was a good outcome. I see the patient a couple of days ago, and you can see here that he's doing very well. And the last point, the last question is about lung transplantation. It's when it's indicated and it is worthwhile to perform lung transplantation in those patients. Our experience in our center is not good. We have transplanted 4 patients, and only one is alive. And it depends also considering the follow-up. So the patient number 4 is alive, but we have only 2 years follow-up. And the patient number 1 is dead, but you can see here that in life 2 years and a half. So I think my personal opinion is not a fantastic strategy. Lung transplantation is good because it's the last one that we have, but no, it's not. You can see here also the 58% 5-year survival from all type of lung transplantations in our hospital. And in this other graphic, you can see that the percent survival, those 4 patients that I explained before. It's another study published recently. We have participated here with our colleagues from the lung transplantation unit, and it's a very heterogeneous, a lot of patients, 64 patients, but it's very heterogeneous and with some amazing results. You can see here that those patients who have a better survival were those amyopathic dermatomyositis, but only a third of them were anti-MDA5. So it's very difficult to extrapolate from these studies. And this is a recent study published, just collecting all the experience. And it seems that it's a good option, but you can see here that the outcome, most of the patients is more than 12 months. It's not enough. It's just a year of follow-up. So I am not sure that it's the best possible situation. Just finishing, only say that we are talking about RP-ILD, but we have to keep in mind also that there are rare manifestations of the syndrome that may produce some type of confusion in the differential diagnosis of patients with anti-MDA5 and RP-ILD. Those patients are dermatomyositis patients. They can develop some type of cancer, lung cancer. So cancer screening is important. It's mandatory in these patients if it's possible. Also, myocarditis have been published or reported. So myocarditis may develop a heart failure that may confuse, the lung tissue and the imaging studies. And also ANCA-associated vasculitis has been described. We have experience from our cohort from Spain, not from our own center, or 6 patients with this complication. And the most amazing situation is those patients who develop rapidly progressive ILD and from the very onset develop a pneumocystis jirovecii infection. So it's not because of the immunosuppression, but because maybe it's some type of relationship with the immune system of the patient. So we have to take into account these points. Just my take-home messages are those 5. The first one is that clinical features, epidemiological issues, or biological parameters may alert clinicians about the development of RP-ILD. Improving our knowledge about pathogenesis, it's important to help the patients for a better therapeutic approach. Therapeutic strategies are far from successful, and we need to have some experience about other therapies, which include antifibrotic agents, JAK inhibitors, plasma exchange, or even CAR T cells. We need to think out of the box. Lung transplantation and ECMO are useful therapies, there's no doubt about that, but we need to learn how properly use both for a better patient outcome. And the last point is the anti-MDA5, even that is a well-recognized phenotype, dermatomyositis, remember that has a wide clinical spectrum that we have to take into account. Thank you for your attention. Thank you very much.
Well, there is a change in the program. First, before the discussion, we are going to present two. We will have 2 case presentations. The first one is presented by Eduardo Dourado. Please, Eduardo.
Hi, everyone. My name is Eduardo. I come from Portugal. I was lucky enough to spend 3 months during my residency here in Pavia with Lorenzo's team. And so it was a privilege, and I thank you very much for this opportunity. Now, I'm going to present a case that has some key issues for us to discuss later. Okay. And since we are about to go to the coffee break, I call this food for thought, a challenging clinical case. All right, so we are talking about a patient of 55 years old. He was a nurse, Latin American, and he had an unremarkable previous clinical history, except being a former smoker. In May 2021, he presented with mild dyspnea and evidence of pneumonitis at the X-ray, and he was treated with levofloxacin, and there was no improvement in his clinical condition. So he was admitted to an internal medicine department where he performed chest HRCT that showed NSIP and OP patterns. At this time, COVID was rolled out and ANA and ENA were both negative, but the patient was treated with glucocorticoids, which were then tapered. He improved from the dyspnea, so he was discharged from the hospital with a low dose of glucocorticoids. This was in June. 1 month later, the first relapse of the disease occurred. There was a worsening of the dyspnea and the patient was admitted to a pulmonology center. Again, COVID was rolled out, another CT was performed, again, NSIP and OP patterns. Lung biopsy confirmed the NSIP, so the patient was treated with 50 milligrams a day of prednisolone, and again, he improved clinically. This improvement was also documented by CT in November 2021 and by his normal lung function tests in January 2022. This was the time by which he would have stopped the glucocorticoids. But 6 months later, the patient presents again to the emergency department with his second relapse. The dyspnea was worsening. He had to do high flow nasal cannula oxygen therapy and again, antibiotic therapy and glucocorticoids. He was admitted to the pulmonology unit, which was a different one than the previous that we had talked before. And again, he had in the CT both NSIP and OP patterns, but importantly, he also had signs of pneumomediastinum. Again, NA and ENA were negative. He did another course of antibiotics. He was treated with pulse therapy of methylprednisolone for 3 days, and the dyspnea improved again. O2 was de-escalated. About a month later, CT showed resolution of the pneumomediastinum. There were no other substantial changes, so the patient was discharged after also having clinical improvements, but needing O2 therapy at home. He was also treated with azathioprine 100 milligrams a day and prednisolone, again, 50 milligrams a day. And he was seen in early September in the outpatient clinic, and he was doing well with 1 liter of oxygen at rest and 3 liters on exercise. So it was decided to taper down prednisolone from 50 to 40 milligrams a day, keeping the same dose of azathioprine. However, a week later, dyspnea and cough started worsening again. Fever started again. And a further week ahead, the patient kept getting worse from a clinical standpoint. So he was referred to the emergency department with his third relapse. By this time, he had a C-reactive protein of 24 milligrams a deciliter with a negative procalcitonin. And again, COVID was negative. He was admitted on the same day to the pulmonology unit, and the blood work also showed elevated ESR, lymphopenia, and ferritinemia with a normal CK. Bactrim was initially used, but due to a skin reaction, it was switched, but he still completed an antibiotic course. He needed not only high flow oxygen, but also non-invasive ventilation during this admission. And a new chest HRCT showed not only the NSIP and OP aspects getting worse, but also, again, pneumomediastinum. And here you can see the CT scans from August 2022 after the resolution of his second relapse, and the CT from September 2022, which was the beginning of the third one. So 4 days after being admitted, he was seen by a rheumatologist that documented no renal phenomenon, no arthritis, no muscle involvement. However, the patient had a mild dysphagia and also a clinical history of mechanics hands that had solved after starting the glucocorticoid therapy. Myositis-specific and myositis-associated antibodies were requested at this time, and anti-MDA5 antibodies were positive. So a diagnosis of anti-MDA5 syndrome was made, and a thoracic ultrasound showed diaphragmatic involvement. Treatment course included methylprednisolone pulse therapy, plasma exchange followed by IVIG for 3 days, and a course of rituximab along with the steroid therapy. The patient did improve not only clinically, but also the physicians were able to decrease the amount of O2 the patient needed. Patient was discharged, and in May 2023, he was feeling well under 25 milligrams a day of glucocorticoids. He was still doing IVIG. However, on the chest X-ray, pneumothorax was identified. So the patient was admitted again. And here we can compare the images from the CT from September 2022 in the beginning of the third exacerbation of the disease, and the CT from May 2023, where we can see not only that he had improved the NSIP-NOP components of his lung problem, but also he had a marked pneumothorax that was treated with a bulectomy and pleurodesis. Right now, the patient is under prednisolone in a low dose IVIG treatment. He has rituximab scheduled for this month, and he's being treated with nintedanib since in the last ward, the last time he was in the ward, there was a histology from the bulectomy that showed marked fibrosis. As a few thinking points from this case, we have to remind ourselves that MDA5 can present in patients with ANA and ENA negativity. Searching for myositis-specific and myositis-associated autoantibodies is crucial for the correct assessment of patients with ILD of unknown cause. Pneumothorax and pneumomediastinum should catch our attention and make us suspect of anti-MDA5 syndrome. And finally, nintedanib could be considered early during the disease course to avoid the fibrotic evolution of anti-MDA5 patients. Thank you very much.
I would like also to call the next case presenter, who's Fornaro, Dr. Fornaro, who's going to present another case, which deals with the same.
So thank you for the presentation. Thank you for inviting me to this wonderful congress. And thank you at first to Professor Cavagna. He wanted that I call him Lorenzo. Thank you, Lorenzo. So I can start my presentation. That is a clinical case quite similar to that presented by Eduardo. So I can start. Marco Fornaro, researcher at University of Bari, for disclosure regarding this clinical case. And this is my clinical case. We were at February 2021. We have this female patient, 56 years old, never smoker, no comorbidities, no familiar history of rheumatic disease, but she had a familiar history for breast cancer. And she underwent the first visit with rheumatologists for arthritis of both breasts. At labs examination, she presented an increment of inflammatory markers, no other alterations were found, and autoimmunity showed ANA negative, anti-CCP negative, and low positivity for rheumatoid factor. So we have this patient with bilateral and symmetrical arthritis, and as if we perform the classification criteria for rheumatoid arthritis, the score is 6, but the clinical at that time was for a diagnosis of rheumatoid arthritis. So the patients was screened as your recommendation for hepatitis B and C marker that were negative, and checked X-ray showed no abnormality at that time. So the patient started treatment with methotrexate 50 milligram weekly and prednisone 5 milligram per day. After 1 year of treatment, the patients called her rheumatologist because she presented cold dyspnea. The first was to exclude the COVID infection, and the test was negative. She was visited, and this is the lab examination that showed a normal inflammatory marker, no other alteration. The patients had fear for breast cancer, so he performed also this marker CA 15.3 that was increased, but there are no signs of breast cancer. We know that this marker can be increased also in ILD, and at lung auscultation, the patient presented fine cravings. So obviously, the patients was assessed for lung involvement with pulmonary function test that showed a restrictive pattern and a moderate reduction in the LCO. And on the right of the slide, you can observe the CT, the chest CT of this patient. A little faster. So again, we can observe the ground glass with apicobasal gradient, some bronchiectasias, and subpleural ground glass, subpleural alteration. So we know we have a patient with a diagnosis of rheumatoid arthritis. We know that the most common pattern, CT pattern in rheumatoid arthritis is UFP pattern, while NSAP pattern is more common in connective tissue disease, as literature teaches us, and as this is our abstract last EULAR from a multi-center Italian study, where NSAP was more common in connective tissue disease, sometimes associated with OP pattern in dermatomyositis and antisynthetase syndrome. But the patients came to our attention in our department presented another clinical manifestations. For the patient thought that this is an allergic reaction for washing products, but we know that this is a typical Gottron sign or dermatomyositis, but there is other alteration. One is the involvement of both the dorsal and palmar side of hands. The second is the presence of these fissure-like lesions on the hands. The third, the presence of megacapillaries on the periungual side of her fingers. So the patient was Hay negative. We retested the patients for ANA with F2 and was a low tittle, but in this case it's important to test also for myositis-specific antibodies. And we found that the patients have MDFI positive. So the patients were affected by MDFI positive dermatomyositis. So it's important after to assess also for muscle involvement, muscle enzymes like MRI, model muscle MMT8 was normal, so the patients have an homeopathic form of dermatomyositis. And for lung involvement, we started mycophenolate 2 gram daily and prednisone 12.5 milligram daily. The patients after 2 months, we were at May 2022, presented necrotic lesion on the hands. So the patient was admitted in our inpatient clinic to start intravenous Hilocross. So we assessed again the pulmonary involvement because the patient was MDFI positive, and we observe also if the patients didn't report a worsening of hair dyspnea, presented a worsening of pulmonary function test, as you can observe. And this is the new chest CT, because in this case, for me, it's important to retest, to reperform another chest CT, because we need the image, and this is the image of this patient. Okay, there are again another tremomediastinum, that is the area around the trachea, but there are also a progression of the ILD, more consolidative area and more ground glass. So we need to discuss this case with a multidisciplinary team in our hospital to give to the patient the best management treatment. Our multidisciplinary team was composed by a rheumatologist, a pulmonologist, thoracic surgeon, and radiologist. We know that MDF5 positive dermatomyositis is related to rapidly progressive ILD that can start nearly to the ILD detection, and despite immunosuppressive treatment, like our case, the patient was treated with mycophenolate. So we decided these 3 points together. First, to exclude the infection causes for these patients. Second, as suggested by thoracic surgeon, bed rest and oxygen treatment. Third, to start another immunosuppressive therapy. So we decided for these patients to start the cyclophosphamide 1 gram monthly for 6 months and methylprednisolone 1 milligram kilogram daily with tapering. After 2 months, the patients had amputation of the second phalanx for the worsening of the necrosis. And after 6 months of treatment with cyclophosphamide, we reassessed the pulmonary function test, and we can observe an improvement of all pulmonary function tests and the new chest CT. So in this chest CT, we can observe the resolution, spontaneous resolution of the pneumomediastin. So we stopped the cyclophosphamide, and for maintenance treatment, we restarted mycophenolate 2 gram daily. The patients, after 2 months, we were at February 2022, had a flare, worsening of skin rash and arthritis, so we decided to stop mycophenolate and started rituximab 2 gram every 6 months. And at last observation, pulmonary function test remains stable, and the patients has no signs of skin rash, no arthritis, and no O2 treatment. I think that from this clinical case, there are these 3 points that I would like to underline. That the first is that MDF5 positive dermatomyositis could start with joint involvement. And as we know, sometimes can be present the skin rash. That the pulmonary function test and chest CT should be performed as soon as possible if a progressive subset is suspected, especially in the presence of risk factor, because we have a window of opportunity to start an aggressive immunosuppressive treatment is necessary to halt the progression and prevent intensive care unit admission. Thank you from Bari.
Thank you very much. Just keep your position, and I would like to ask all the speakers to come to the podium because we now have the discussion of the clinical cases and the presentation. And while I wait for the audience to raise hands for the discussion, I would just like to make my first question, if you have another, my first question to all those who wants to answer. What about the diaphragm involvement? Why, when, and how do you screen it? Because we have seen some cases, one has been presented, and this could be a contraindication for transplantation, as we know. So we should be aware or how is the diaphragm. And so I would like to have your opinion on this. Diaphragm involvement, muscle diaphragm.
La evaluación de la fuerza del diafragma.
All the patients with inflammatory myopathy who presented with a classical form develop a worse outcome than a myopathic dermatomyositis. They say that one of the causes was that could be muscle involvement in the classical form that may contraindicate or produce some type of problems with ILD, with lung transplantation. In my experience, all of the patients that are lung transplanted usually don't have a severe muscle disease, because usually the muscle responds very well to the armamentarium that we have, immunoglobulins or other immunosuppressive drugs. So it's not, usually it's not a problem for that, my opinion, my experience.
Okay.
Just for the screening, maybe in that case, we should consider dealing with a pneumologist doing the pulmonary function test, because it can be captured by just looking at the DLCO corrected for volume. Then unless you have a pulmonary hypertension, the fact that the DLCO corrects well for volume, it might be a hint for that. So then could be evaluated.
I'm answering instead of Professor Rheumatic Agarwal. So in our experience, diaphragmatic involvement is not always considered by clinicians, and it's a really important issue. And this is one of the cases when I think that lung ultrasound, diaphragm ultrasound is very important. We have the skills because our intensive care unit specialists are able to evaluate to diaphragm involvement, but I think that also rheumatology should be keen to learn this methodology, because diaphragm involvement might be not related to the occurrence of a peripheral muscle involvement, and IVIG are very, very effective in these patients. So we had good results. We should think that diaphragm could be involved even without involvement of peripheral muscle disease. This is at least our experience.
Professor Giacomo.
Thank you to all the speakers. It was a very interesting session, because we listened many different opinions about the MDF5 syndrome, and also how large is our armamentarium, but therapeutic armamentarium. But there are some differences among us. And so I would like to ask Professor Moreno, I really appreciate your presentation. You told, sorry, I try to go far away from the, you told that you generally prefer to start with calcineurin inhibitors. And generally, calcineurin inhibitors are a very good strategy for T-cell dependent disease, because the main effect of calcineurin inhibitors is inhibition of IL-2. Cyclophosphamide has a widespread effect in many different cells, more in granulocytes and in macrophages. So deciding the treatment means, I believe, that one pathway is more active than others. Do you have any biomarkers in your experience that suggests you to use an approach with calcineurin more than cyclophosphamide? The last case showed that a very quickly and aggressive treatment could change the outcome of the patients, and calcineurin generally has a slow effect considering the intravenous treatment. So I would like to know, what is your thinking about deciding to use calcineurin as first treatment?
Okay. Well, I really don't know the mechanism and why tacrolimus is working better than cyclophosphamide. But what I can say is that in our experience, tacrolimus is a very good drug and it works very well. And cyclophosphamide is very toxic. We don't use in our hospital cyclophosphamide, we use mycophenolate or tacrolimus. The way that acts the drug, really I don't know. What it's important to keep in mind is that probably tofacitinib makes a lot of sense to be used, taking into account the idea that the MDA5 is in the middle of the cytoplasmic cell and plays a role activating the interferon 1 and the JAK pathway as a JAK inhibitor. Even other JAK inhibitors, as a baricitinib or the new ones, are not so useful. It's very curious. I don't know why. So we try to know the mechanisms, but we really have no knowledge about that. And we rely on clinical grounds. It's our everyday practice. Sorry.
Good morning. And I want to ask to everybody if you think that it will be dangerous to wait for the antibodies when you have very aggressive disease. I mean, density care for MDA5 is not screened. So when you perform normal screening, infected disease, all the assessment, but disease is very aggressive, you should really treat it before, or you always wait for the antibodies?
In my opinion, the problem for the treatment of the severe interstitial lung disease in this patient is to actually exclude an infected disease in this patient. So, okay, the autoantibodies have a great diagnostic value, but in the first stages, the diagnostic suspicion of myositis underlying interstitial lung disease, in my opinion, should be confirmed by a BAL, probably. You could agree, Federica, okay? Or even to with a biopsy, a lung biopsy, when the clinical picture allows this approach, okay? So when the patient has a low response to antibiotics, okay? Multiple antibiotics therapy, so we can add steroids. Some improvement is clearly possible. And so we can wait for the autoantibodies. But also the negativity of autoantibodies not allowed to exclude at all the diagnosis of myositis. So it's very difficult to discriminate what is the limit from infective disease to autoimmune disease in these conditions.
Sorry, I would add only that in my practice, sometimes inflammatory markers are normal in our disease. I don't know if is also your practice.
So just coming back to your question, I get your point, but I think it really depends on the because if you have a clinical, you can make a clinical diagnosis even without waiting for the autoantibody panel. And in that case, I don't know if you agree, Gianluca, but even though you might have the suspicion that an infection is superimposed, but a patient does have a diagnosis of dermatomyositis with a progressive lung disease, then I would still do immunosuppression. I would like to have the autoantibody panel to also justify what I'm doing, and even though from the BAL, I can have then the retrieval of a fungal infection. And so I would, of course, cover the patients against that, but I would not delay the immunosuppressive treatment because the two things can coexist and the diagnosis doesn't change. He will most probably die of ILD than of aspergillosis.
I would like just to ask, to add that if we behave like this, probably sometimes we could skip ECMO, because sometimes we just go to ECMO because we have failed to do the proper diagnosis before, and then ECMO becomes something that we cannot we cannot deal with, and sometimes the patient even doesn't have the diagnosis when he's in ECMO, and this is a big problem, and we have seen some cases like this in our hospital, and this is a very big problem.
So I totally agree with my colleagues, but usually the antibody in my hospital, you can have the antibody the same day.
Yeah.
You ask for your colleagues,
it's fast.
Please
Yes.
give me, and it's important. Of course, it's all in the same line that they had said.
I have a question. Mariela did ask a challenging question in her presentation. She asked, should all interstitial lung disease patients should be evaluated for autoantibodies related to myositis? After your presentations and after the two cases that were presented, what is your answer to that question?
Yeah. Well, I would say that at least most patients should do this screening. It's not that much of a complex exam. Sometimes, for example, the patient I presented was thrown at so many exams, some of them more complex than doing a blood workup for myositis-associated, myositis-specific antibodies. So I think that at least if the patient has a first relapse, this has to be considered. I don't know what is your opinion.
I'm nothing to add to the opinion of Eduardo. It's probably. Okay. The boss stopped the discussion.
Well, let's take a break and return in a few minutes. I will come back.
discussing in this interesting meeting. Just for people who don't know me, I'm a Spanish rheumatologist, Miguel González, and I'm glad to be here in this nice city. And I thank the organizers, in particular to my close friend Lorenzo, for inviting me to stay here and to chair this session. So first, let's start with the first speaker. It's going to be Dr. Montecucco. He's going to talk about rheumatoid arthritis and lung manifestations, clinical aspects, and screening.
Thank you, Michelangelo. Thank you, Lorenzo, for the terrific job organizing this Congress. Among the multiple and variable manifestation in that may occur in rheumatoid arthritis, certainly the most important from a clinical point of view is interstitial lung disease, which is a relevant extra-articular manifestation of rheumatoid arthritis and still a clinical challenge. As Antonio Manzo said yesterday, the lung is a primary site of pathology throughout RA development, and mucosal damage induced by, for instance, cigarette smoking or air pollution may induce citrullation of local proteins, and in predisposed patients, an autoimmune response to citrullinated antigens, leading to a bulk expansion with the formation of neolymphogenetic structure, with follicular lymphatic follicles, and true germinal centers, able to produce in loco auto antibodies to citrullinated peptides, so ACPAs. As we can see later in the disease in synovial tissue, rheumatoid arthritis. So it's not surprising that interstitial lung disease may occur sometimes before clinical presentation of the articular disease, the joint disease in rheumatoid arthritis. And as a matter of fact, near 10% of all interstitial lung disease occurring in patients with rheumatoid arthritis are present before joint disease, over joint disease. And another 10% is co-occurring with clinical joint involvement, so in very early arthritis. Just to consider that the diagnosis of early arthritis is a very difficult task in clinical practice, and we have found patients presenting with arthritis, polyarthritis, even erosive arthritis, with ACPA positive test and interstitial lung disease, but this patient had sometimes Sjögren's syndrome or antisynthetase syndrome. So this just to consider that the presence of arthritis, of early arthritis and interstitial lung disease doesn't always mean rheumatoid arthritis. Anyway, the vast majority of interstitial lung disease occur late in the course of the disease, and we are the precise prevalence and incidence of RA-ILD are still unknown. We know that there are a number of patients with subclinical disease, so with lesions detectable at high-resolution computer tomography, but in absence of clinical symptoms. The percentage and the clinical fate of these patients are still matter of debate. Is largely unknown. And what we can calculate is that clinical relevant, clinical significant ILD in RA occurs in nearly 10 to 15% of all RA patients during the whole course of the disease. As you know, the histomorphological pattern more frequent in rheumatoid arthritis is UIP, and this is in contrast what we observe in other connective tissue and rheumatic diseases. The progression of ILD in rheumatoid arthritis occurs towards a severe functional impairment or a severe structural damage radiographic occur in nearly 50%. This means that a half of our patients will not progress or may even improve spontaneously or drug-induced. And we have to consider this point, which is very important when we are planning a therapeutic strategy in our single patients. Progression may also occur sometimes, unfortunately, fortunately not so frequently, but with acute exacerbations. Acute exacerbations in rheumatoid arthritis, ILD, are a very, very severe condition, and differential diagnosis with infections is mandatory, as was the prompt and strong starting of immunosuppressive treatment when infection was excluded. The prognosis of RA-ILD is quite bad. The mortality rate is increased in patients with ILD with respect to rheumatoid arthritis without ILD. Pulmonary comorbidities represent the second cause of death in RA patients following cardiovascular disorders. And patients with UIP, of course, have the worst prognosis. However, the survival of patients with RA-ILD has dramatically improved in the last 20 years, from 33 months to 98 months and more. And the best way to improve survival is early detection of ILD. So once again, the earlier, the better in rheumatoid arthritis, even for lung involvement. Strictly associated with an early detection is the recognition of patients at risk of developing ILD. The most important risk factors are old age, male sex, and smoking habits. There are also genetic risk factors and disease-related risk factors. The most important genetic risk factor is the GOF variant of the promoter of the gene encoding mucin 5B. This variant is strictly connected with the risk of developing UIP. Unfortunately, this test is not routinely available in many clinical settings. On the contrary, APA testing is worldwide available, and APA are strongly associated with ILD, since the vast majority of patients with RA-ILD are APA positive. This is a recent study published a few months ago on Lancet Rheumatology, and that shows that the analysis of fine specificities of autoantibodies in rheumatoid arthritis might identify a subpopulation with a very high risk of developing ILD. If this data will be confirmed, this is will be a very important tool in our hands. But we have just to wait for. The most important point in prevention of ILD, in my opinion, is the association of ILD with active disease, with the persistently active disease. This means that if we treat our patient correctly, following the recommendation of treat to target strategy, so maintaining our patient in low disease activity or remission, we may prevent or at least delay the development of interstitial lung disease. This is a very important point, in my opinion. The central point, however, is screening. There is no doubt that the gold standard is HRPC, but we cannot screen every patient every year, for instance. It's not cost effective. And there is no consensus as to which patient with RA should be screened and when. There are no published guidelines for screening. So, in my personal opinion, the best way to screen is a careful, repeated, regular clinical evaluation. Paying particular attention to patients with one or more risk factors. We have to keep in mind that crackles, Velcro crackles are quite characteristic for pulmonary fibrosis and occur early in the course of the disease. So physical examination is still the milestone of screening of in these patients. Ultrasound screening is promising, as always is ultrasound studies. Ultrasound studies. However, it has been extensively used during the recent pandemic. However, it needs still to be standardized. In our hands, it's very, maybe too much sensitive and not so very specific. The last point is monitoring of patients with ILD. There is, once again, no consensus on how patients with RA-ILD should be monitored. A reasonable advice might be a query about new or progressive respiratory symptoms at every clinic visit, measure pulmonary functional tests every 3 to 6 months according to the risk assessment, and maybe perform an HRTC at least yearly. No evidence at all. Okay, it's just clinical methods.
Makes sense.
Okay, the risk is just the extension, the severity of functional impairment or radiographic damage, and the progression of functional impairment in the last 6 or 12 months. Okay? So, to conclude, the take-home message are that RA-ILD may occur at every time during the course of rheumatoid arthritis, even before involvement. Clinically significant ILD, mostly UIP, occurs in 10 to 15% of our patients and progresses to a severe functional impairment in about 50% of cases. Main risk factors for ILD are old age, male sex, smoking, and ACPA positivity and uncontrolled disease activity. ILD is associated with increased mortality in RA. However, early ILD detection improves survival. Screening and monitoring procedures are still matter of debate. Patients with one or more risk factors should be screened for symptoms of lung involvement and have careful lung auscultation at every clinical visit. Patients with RA ILD should also perform functional tests at least every 6 months and HR-CT yearly. I want to conclude with the acknowledgement to the my fantastic team of physicians and clinical scientists working in Pavia. I love you guys. Thank you.
For sure, Dr. Montecucco, you are entirely right regarding your colleagues. The next speaker is going to be our colleague from Lisbon, Professor João Fonseca, who is going to talk about rheumatoid arthritis and lungs issues on therapy. That is very interesting.
Hello, everyone. Thank you very much for the invitation, Lorenzo. I guarantee to you, it's a priest-like feeling standing here. Okay? So it's a different way of giving a talk from this perspective. So I'm having a mission that goes very well after this talk with 3 points that I choose to make. The first one is centered in what we know for sure. So it's a very brief part of the presentation. And the middle part regarding the impact of RA treatments on lung is the major one, where we have in fact a lot to say and a lot to discuss and a lot of doubts indeed. And then the final part is the treatment, what we might say the specific treatment of rheumatoid arthritis, ILD related disease. So starting for what we know for sure, this we know for sure for many years. So the pneumonitis is associated with MTX, is associated with leflunomide, is associated with sulfasalazine, is an hypersensitive reaction. It is uncommon, fortunately. It is very severe and forces us to stop the treatment. It is important to remember that leflunomides, after an MTX reaction in this type, is increased in terms of risk of having the same problem with leflunomide. And also there is a certain degree of difficulty in separating an acute episode of ILD aggravation in a patient with a previous ILD from a pneumonitis of the introduction of MTX in the same patient. It's something that is obviously a little bit complex to discriminate. So the rest of the presentation is centered in what we partially are sure of, but sometimes we face other physicians and clinicians and also the patients looking at Google with a lot of doubts and a lot of questions. And the first point is MTX. We have plenty of information now reassuring us that MTX is not inducing ILD. But having said that, I'm sure that those that see a lot of RA patients face the issue of having other clinicians, pharmaceutic colleagues, and also the patients per se and the family worried about MTX and what to do with MTX. And I think that is important to highlight the strength of the information related to that. So I would like to bring the attention to the Sparks Rheumatology 2021 paper, reviewing over 15,000 patients with MTX exposure in clinical trials, and to show in that paper that regarding known infections, respiratory adverse events, the MTX influence is null, okay? And then the data coming from the paper in European Respiratory Journal 2021 that shows original data, the discovery data from France, and then several other ports that were compared, over 1,000 patients. And you see that the combined analysis, if has any sign, is a protective behavior of the exposure of MTX and not a risk factor. And also the paper from Denmark joining over 30,000 patients from NPR and DEMBU and reassuring us in terms of the MTX effect on the risk of ILD, again, a sign towards the protection. And finally, also the data coming from early arthritis cohorts, so patients that have been followed up since the beginning, and a clear sign of a delay in terms of survival curve of the initiation of ILD in those exposed to MTX comparing to the others. So this is important just to remember in our minds to be sure when we argue with other colleagues. So summing up in the first sentence of the major papers related to that, leflunomide, we have this paper from 2016 suggesting that leflunomide do not induce ILD, but it might aggravate at least pre-existent severe ILD, and this is something that we have to take into consideration. And then we have the long discussion around TNF inhibitors. So papers coming from 2011, so quite early in the story, an analysis of 122 reports. But everything that we have is what we might call relatively light science. Then we have an analysis of 7 cohorts and 26 case reports, and a follow-up study of 163 patients with CT scan, and a follow-up showing that some of the patients developed ILD. But when we consider this, we have to take into consideration other publications, namely the market study database, over 10,000 patients, no difference in incidence and complications of RA-ILD between TNF inhibitors and other biologics. Of course, the question is not exactly the same, but it's something that we have to bear in our minds. And the other publication referring to the incidence of exacerbations of all pulmonary comorbidities, so not on ILD, but everything, okay? Comparing TNF inhibitors and abatacept, and this, of course, is relevant because of all the discussion on abatacept, and we have a presentation on that. So it might be a problem, but it's not such a huge problem. Probably it means that some patients are sensitive, and we have to take this into consideration. I bring also this recent publication, 2023, from JAMA. We have already discussed a little bit tofacitinib in the intervention and potential interest in ILD and in other diseases. And here is the protection as comparing to adalimumab. So adalimumab is the reference. So the tofacitinib associated risk of developing ILD is at least lower than adalimumab that we can say from here. Other things could be discussed in this paper, but I think that it's a claims database, almost 30,000 patients. We have to take this with care, but at least it shows something that has to be clearly analyzed. So the story around non-TNF biologics and the story around what we have heard, the importance of controlling the disease. So if we have patients that are well controlled, the probability is that not only joints will be safer, but everything inside the patient related with the disease is also in a safer position. And so goes with the line. I bring here two observational studies with relatively few patients, 93, 62, pulmonary function test, CT scan. The image in the center goes to the small study with 49 patients. But again, here is to bring a little bit to the point to abatacept, showing here that abatacept seems to be a little bit different than the other biologics. And that is been the observation also in another 2 observational studies, a positive systematic review also on that. And this publication that I'm highlighting here with the images suggesting that abatacept might stabilize RA-ILD related regardless of the use of MTX. So meaning that MTX, of course, has an effect, and the effect is measured by a better control of joints, lower dose of prednisolone, but in terms of stabilization of ILD disease, it seems to be more or less the same having MTX or not when you are on abatacept. Small series on rituximab, highlighting here the series from Leeds, a cohort of 56 patients, stabilization of pulmonary function tests. You see the trend going down in each one of the graphs and then stabilizing or going a little bit up in the pulmonary function test. Then we have other small series on the same subject. Tocilizumab also has some observational studies. But the point I would like to make in this slide is the Tardella Immunopharmacology 2022 patients publication, where 75 patients have been followed up for a period of 18 months. And not only abatacept is here the point, but also JAK inhibitors, bringing again the question of JAK inhibitors and the possible role in stabilizing ILD disease. And this is also the story in this recent clinical and experimental rheumatology paper, suggesting the stabilization of the pulmonary function tests of patients treated with tofacitinib, but the survival of tofacitinib with these patients is lower, related to more infections. But these patients are also older, so the patients with ILD. So in the previous presentation, arguments regarding this. Of course, the subject of this presentation was not ILD per se, but lung-related disease, and we have other points of touch of the rheumatoid disease in the lung and airways. We don't know much about the laryngeal involvement. Those that see many RA patients recognize this. There are a few patients that change the voice and have some symptoms here, but we don't know very well what to do to them. Asthma, of course, respond to corticoids, COPD also, and it's interesting that MTX can also, in some patients, induce mild improvements. Bronchiolitis is uncommon, fortunately. There are reports that the obliterans form respond better to TNF inhibitors and the follicular one to rituximab, so it makes sense, but a few cases been clearly analyzed with this. Bronchiectasis is a problem, and the discussion that we will have later on about the abatacept will address this. This is a concern, recurrent infections, biologics, etc. This is an open question if we should or not keep these patients in a circle of infections. Pleural infusion clearly related with disease activity and the need for control of the disease activity, but of course, a workout has to be made to be sure that other things are excluded, such as neoplasia and tuberculosis. Pulmonary nodules is also another classic discussion in rheumatoid arthritis science, and it's pretty unclear what we should do. It should be, of course, case-by-case analysis and balance if we stop MTX, TNF inhibitors. It depends a lot on the patient and the symptoms. Then recurrent infections and tuberculosis is also an open story, never-ending story. A comment on pulmonary hypertension. So a subtle increase in terms of incidence. Some of the patients are a little bit like primary hypertension, very few, most secondary to lung disease, of course. What to do to them? Probably exactly what we do to other patients in other conditions. Then the story of deep venous thrombosis and pulmonary thromboembolism. We knew already that it was more frequent in rheumatoid arthritis. JAK inhibitors gave us an opportunity to rediscuss this, and we should be aware, of course, of JAK inhibitors regarding this. A short, very brief comment on the specific treatment of RA-ILD. So this clearly comes from the science of pneumology, and rheumatologists have learned with them, and we have to treat these patients, of course, with them. And we've heard that half of the patients are not progressing, but those that progress have a bad prognosis, and there are acute exacerbations. And these are the key words to actively engage in the treatment. Corticoids have to be increased in severe patients, but not to high doses. The discussion on the uses of azathioprine and IMF, MMF, which are clearly important treatments for ILD in other contexts. But here we have to balance quite carefully, because we have a publication saying that azathioprine in RA patients might increase indeed mortality. So the overall effect might not be as interesting as that. And it is a little bit difficult to combine MMF or even calcineurin inhibitors with patients that are with biologics. We know this, for instance, from transplant patients, that we have to treat them after being transplanted and having rheumatoid at the same time, and being exposed to biologics, the risk of infection is very high, and the combination of these drugs is not easy. Acute exacerbations, we've heard already here the discussion on other diseases, and the story is the same. Lung transplantation, we've heard also about lung transplantation. It's hard to have good results, and here the story goes in the same way. Brief comments to fibrosis. So the end stage of the story. The INBUILD study included 87 patients with rheumatoid arthritis. So the results of stabilization of the fibrotic process are applicable to rheumatoid arthritis, and so this is also an option. And pufridone might be also an option, because the TRAIL-1 trial was published recently. It was interrupted due to COVID, slow recruitment, so it was underpowered. Results were not what were expected, didn't met the primary endpoint, but there was a decrease in the steady decline, so a slowing of the steady decline of the pulmonary function test, and safety was okay. It was comparable to what was previously observed in other patients. So pufridone can be also an additional option. So because of this, some colleagues have tried to make logic of all this story. Of course, the part that you have on your left-hand side is easier. So you started MTX, there are pulmonary symptoms, we have ruled out other manifestations, so we go into the pneumonitis story and we have to stop MTX, etc. The problem is what is going to be our positioning regarding ILD and the way we will adapt the treatment of RA if we have that information in our hand. The first point is the one that I've made. A lot of patients will be very worried about MTX, and we have to engage with them in a discussion about the fate of these drugs. So, will it be stopped or not? There will be patients that want to stop the drug, and we'll have to adapt the treatment on their behalf. And we have evidence that certain biologics have apparently a better effect on ILD, such as abatacept, tocilizumab, and rituximab, and maybe also JAK inhibitors. So probably we should go into that treatment option, even if the patient is not as active in terms of joints as that. And if the patient is already in one of those drugs, it might be the case that in that specific patient, the option of changing to another one of these drugs might be a useful option. We're not sure of this, of course, and I'm just referring to a paper and giving a little bit of my opinion, because this is highly debatable, of course. And then we have the severe cases and the exacerbations of ILD, and then we have the specific treatment of ILD in these cases. And here again, we don't have many doubts about it. And that's the story I would like to bring to you. And thank you again to all of you, and particularly to the team in Lisbon. Okay, thank you very much.
And thanks a lot, Professor Fonseca. We had two wonderful talks, really. Now this is the turn of my close friend and co-organizer of the Congress, Gianluca Herret, that is Associate Professor of Rheumatology at the wonderful University of Sassari in the wonderful Sardinia.
Good morning, everyone. Thank you, Lorenzo, for having invited me to present. Okay, this very challenging topic that is bronchiectasis patient with RA. So let me set the scene here of what about we think is bronchiectasis. This is fundamentally a chronic inflammatory disease with airways dilatation, bronchial wall thickening, bronchial wall scarring, and also airway remodeling. This is also visible in CT scan that represent the gold standard technique, but I have no time to cover specific details. Going forward to the pathophysiology of disease, we have no clear evidence of moments that are relevant, but we think that we have
more important, neutrophil-driven inflammation with production by neutrophils of a broad range of pro-inflammatory cytokines, neutrophil extracellular traps, and also digestive enzyme that may also lead epithelial damage. We have mucus gland hyperplasia, metaplasia with hyperproduction of mucus plugging, and also obstructions of bronchi. And we also have, that is very relevant, impaired mucociliary clearance. As a result, we have bacterial overgrowth, colonization, and infection. To the patient, this means specific features that a chronic cough, increased sputum production, chest pain, shortness of breath, but more relevant, this means recurrent infection that may also drive disease progression. Briefly, bronchiectasis is a clinical syndrome. Half of patients have no underlying disease, so we call this idiopathic. A large proportion of patients have, of course, tuberculous infection and non-tuberculous mycobacteria. A small proportion of patients have rare genetic disease like cystic fibrosis. But to stay in the field of rheumatology, we also know, and this is the reason I'm here speaking about, that array is associated with bronchiectasis in a large proportion of patients. So the question is, how many patients with array have associated bronchiectasis? We don't have a clear answer to this question. We have two meta-analyses with a very heterogeneous results, high variability, because we have small studies with different patients with different definition of bronchiectasis. In some studies, we have only standalone bronchiectasis. In some studies, we have also bronchiectasis in the context of a fibrotic interstitial disease that are two different diseases. So, and also there are differences according to clinical scenario and CT scan strategies, because if we perform CT scan in every patient because of research purposes, we have at least 30% of our patients with radiological sign of bronchiectasis. On the contrast, if we perform only in patients that are symptomatic, we have only 1 patient out of 10 with radiological evidence of bronchiectasis, and this, of course, may impact our treatment. So, how patients with array have such increased risk of bronchiectasis? This is a very old model proposed by Cole in 1986, but it's still the model we use. They feel that initial infection in susceptible individuals may drive extensive inflammation with the production of pro-inflammatory cytokines and also epithelial damage. So we have mucociliary impairment, obstruction because of mucus plugging, and a new course, a new vicious cycle of infection. Patients with array may enter the cycle because they, of course, may have an increased risk of infection because we use immunosuppressive drug to treat their clinical manifestation, and because they have an inflammation. As previously mentioned by Professor Montecucco, it is very clear that patient, not only patient with clinical manifestation, but also patient in preclinical phase of disease, they have a specific and highly organized lymphoid tissue able to produce specific array of antibodies and to lead in a not so small period of time to clinical manifestation. This is a very, very organized tissue with a T and B cell separation, high endothelial venous, and also follicular dendritic cell, able to present the antigen. I previously mentioned that in general population, neutrophils are the leading cell in inflammation. But how do stars are linked? We have evidence that neutrophils may produce neutrophil extracellular traps that are rich of citrulline peptide, and this may breach immunotolerance and may lead to inflammation, lymphoid inflammation with production of antibodies. So taken together, this data is not surprising that patients with RABR are mostly patients who are positive for rheumatoid factor, are positive for ECPA. There are recent data, there is recent data from Journal of Rheumatology in patients with standalone bronchiectasis, in which it seems that older age at the moment of RA diagnosis and low BMI represent risk factors for RABR. This is an interesting finding because we know that in patients with interstitial lung disease, high BMI is a risk factor. So we can speculate that two different lung diseases have different risk factors in patients with RA. There is also some genetic data with increased prevalence of mutation for the cystic fibrosis gene in patients with RABR, and also some association with allele of HLA gene. One relevant question is, which is the spectrum of pathogens in patients with RABR? We have only one data coming from a new paper presenting findings from a database of 340 patients with RABR. And surprisingly, we have the same spectrum of pathogens we can find in general population of patients with non-cystic fibrosis bronchiectasis. So we have NTM, Pseudomonas aeruginosa, Haemophilus influenza, and also fungi. So how the treatment profile of our patient may impact the risk of having an infectious disease in patients with RABR. As previously mentioned by Professor Fonseca, of course, biological treatment may be at increased risk. These are a result of a small retrospective study, only 47 patients with RABR. And as you can see, there were 93 infectious events corresponding to less than one event per patient year. But what it's really important that patients with biologic are a high risk of developing infection in patients with RABR. And also in the group of patients taking biologics, those patients taking etanercept and rituximab seems to be at lower risk compared with other drugs. Similar results come from an Asian database with 340 patients, in which again, glucocorticoid use and also biological agent may represent a risk for infection. We have disappointing or contradictory result. This is a recent paper from a two center from the UK, a retrospective study, 68 patients under rituximab and 47 patients under TNF. As you can see on the right side, patients under rituximab have a longer period without infection compared with patients under TNF. So it seems again that patients under rituximab may have less infectious event. That's quite surprisingly. How we should treat our patient with RABR that have recurrent exacerbations, so more than 3 exacerbations every year. We have no specific recommendation, so we should follow recommendation by BTS on the treatment of non-cystic fibrosis patient with bronchiectasis. So we should treat accordingly with pathogens. In step 3, if we have Pseudomonas aeruginosa, we should treat with inhaled antibiotics or macrolide. If we have other potential pathogenic microorganisms, we should treat also with macrolide. In severe patients, we should treat with chronic intravenous antibiotics. Patients should be advised to receive flu vaccination, anti-pneumococcal vaccination, and also we should replace IgG in patients under rituximab with low level of IgG. Of course, it's relevant to have availability of a consultation with pneumologists in such complex patients. Moving forward to the prognosis of patients with RA-BR, we have small data. This is a study published in 1977. As you can see, there are only 30 patients in every group. And as you can see, patients with RA-BR are 7 times more likely to die because of bronchiectasis compared with the general population. 5 times more likely to die compared with RA, and 2 times compared with bronchiectasis alone. Similar data from this cohort of European bronchiectasis patients with 150 patients. As you can see in the line with blue circle that represent RA-BR, they have less survival compared with bronchiectasis patients. So they have a double risk of mortality, but what's more important in this slide is that the risk does not seem to be related to lung infection. So they think that disease activity, maybe also cardiovascular mortality in such a patient may drive this increase of mortality. Concluding with some messages, only 1 patient with signs of lung infection have bronchiectasis, and patients that are seropositive, older, and with low BMI have high risk. We should take cautious to treat our patient with biological drugs, and in this group, there are small evidence that etanercept and rituximab may carry a low risk of infection. Mortality appears to be double in such patients, and we don't know really if a driver is lung disease or cardiovascular disease. And again, all this data should be taken cautiously because of high heterogeneity. 1 second just to promote our incoming Congress in Alghero with Lorenzo Cavagna. Thank you for your attention.
Thanks a lot, Gianluca. It will be a pleasure also for the next Congress in a very lovely place. Now, the discussion is open. Is there any question? Professor Giacomelli?
I have 1 question for Professor Fonseca. And I listened to beautiful presentation. The first one of Professor Montecucco, and the second one, your also the third is very good, but is a different topic. Sorry. And I would like to put together what both the speakers told us. The Professor Montecucco clearly defined the outcome of the patients. Was one of your first steps. 50% of patients do not progress. It's right. I remember very well. Still, I remember very well. In some years, I don't know. Then you show some data about the possible stabilization of tofacitinib in some studies. The Turkish study that was maybe the most important about this study had some issues that I would like to share with you, and I would like to know your opinion. The first was that the analyzed patients were very low, less than 20. The second one is that there is no definition of progression. We didn't know how many of that patients will be stable because they had a stable disease or not. And the third one is that we, without knowing if the patients will progress or not, it's difficult to define what is the outcome of that patients considering a drug like tofacitinib. So in conclusion, I would like to know if you think that this kind of study are helpful, or if we need to change our mind and better to define the disease and then evaluate the study. Otherwise, we could have some misconfounding data. And maybe we think that some drugs should work, and maybe doesn't work because the population that we are treating is different from what we observed in the study. And so we decide that this drug is not good, or we don't use the drug in patients that could be treated effectively with this drug. So I will take with attention the result of this kind of study if we don't have a clear definition. Otherwise, we could really mistreat the patient. What is your opinion about this?
Yeah, thank you for the question. I agree with you, but I would extend the comment to the other observational studies, not only this one. So the lack of understanding of how progressive are the patients is an issue in all these studies. And we might have indeed patients that would stabilize probably in a way that we're not sure exactly how. And also in those studies that we have a measure of how things were evolving previously, we are not sure also if those patients that were degrading their function would somehow, without being exposed to the drug in question, not only tofa but others, would indeed stabilize, because that's the nature of the evolution of some patients. So indeed, we are in a swamp in terms of the analysis of all these data. I think that clear associations with the risk of ILD appearance is something that we can be sure and relatively safe that these drugs are not causing ILD, and comparing, for instance, thousands of exposures to non-biologics, non-TNF biologics, or the case of tofacitinib in that 2023 patient from the comparison of tofa with adalimumab. So these are information that is relevant, because we know that patients over time will evolve into ILD, some of them, of course. And so if we are having a negative association, this is something of interest. But the rest of the observation studies, yeah, I agree, we have to take it with a grain of salt. Yeah. I don't know if you want to comment.
Hi, Jorge Rojas from Mexico City. In my mind, I have a lot of questions, but I think I just have time for two. Two, please. First, what could possibly explain the improvement in survival in this Clive Skelly manuscript that was published 2 or 3 years ago? And second, what is the effect in survival of tight RA disease control?
There is no data of the improvement in survival of tight disease control. There are data only on the fact that uncontrolled disease is a risk factor for developing ILD. So ILD develops more frequently in uncontrolled patients than in controlled patients. Patients under treatment with low disease activity on remission. So there is we have no data on the impact of disease control on survival. We have only data on early ILD detection and survival, because probably these patients, independent of the treatment, are followed in a better way, I think, or we change treatment by TNF alpha to another treatment, or we add other immunosuppressive drugs in patients with rapidly progressive disease. I don't know why, but early ILD detection is associated with improved survival.
Thanks a lot. I think that we should move to case discussion. You're allowed. You're my boss. You're my boss. You're allowed.
For Professor Henry. I wonder why smoking is not a risk factor for bronchiectasis.
Yeah. In fact, there are a lot of data that smoking is not. Really, it's not. So I presented all the results about BMI, but also seems the ILD and bronchiectasis patient may have a different risk profile. So patients with ILD are higher BMI, male, mostly male, with smoke, of course, and patient with bronchiectasis, not clear, but more likely female with low BMI and no smoking.
Oh, okay.
It's my boss.
I'm sorry, Gianluca, just one question. So practically we have two kinds of lung involvement. High airways and low airways, is that correct? So bronchiectasis and then interstitial lung disease. Is that correct? Thank you, sorry. Okay, 3, bronchiolitis. So middle, high, and low. Exactly, thank you so much.
So, one question. How is the level of autoimmunity, in your opinion, for bronchiectasis in rheumatoid arthritis? Is there also maybe also an autoimmune problem? Because it was very strange that they improved with rituximab.
Yeah.
You have no answer, no, but
yes, I think the answer is the prevalence of only radiological findings of bronchiectasis, because most of patients they have bronchial wall thickening without clinical symptoms. So I think that in those patients, we can find some evidence of inflammation in the bronchial wall. So I think in a large proportion of patients, maybe some manifestation of disease.
Perfect. Now is the turn of a case discussion. We have two presenters from Pavia. The first one is Dr. De Stefano. We start from the bitter and we will finish with the better, but not because of the presenter, because of the case presented.
Yes, thank you. Good morning, everyone. Thank you, Chair, and thank you, Professor Cavagna, for inviting me to present this case. Today, I will present a clinical case that is representative of how it's challenging to interpret and manage patients with lung involvement in rheumatoid arthritis, who have rheumatoid arthritis. And we'll try to analyze every passage we had to interpret. The case is that of a 43-year-old woman, smoker, who had been diagnosed with autoantibody positive and erosive rheumatoid arthritis 1 year earlier. Due to the intolerance to methotrexate and the ineffectiveness of leflunomide, we decided to start TNF inhibitors. And among them, we chose etanercept due to the presence of a latent HBV infection, because it has considered the best in terms of safety. After an initial benefit, etanercept could no longer control synovial manifestation after 1 year. Moreover, they were accompanied by respiratory symptoms that the in-depth determination described as moderate restrictive syndrome with fibrotic honeycombing lesion on chest CT. What can we say about this new organ manifestation? Whenever we face a pulmonary involvement in patients with rheumatoid arthritis, we have to consider several etiologies. The differential diagnosis includes an exarticular manifestation of rheumatoid arthritis or of another rheumatic disease, the presence of infection that often complicates the immunomodulating drug we use, drug reactions, as in the case of TNF inhibitors, and patients' comorbidities. In this case, we interpreted the lung involvement either as an exarticular manifestation of an uncontrolled rheumatoid arthritis or a drug or a reaction to TNF inhibitor etanercept. and we decided to change mechanisms of action and started abatacept, which is considered safe and effective, especially in patients with autoantibody positive rheumatoid arthritis with lung involvement. Monotherapy with abatacept in our patients succeeded in ensuring articular remission and stability of lung involvement for 3 years, until due to the reactivation of hepatitis B, it has to be stopped to promote the resolution of the infection. 6 months after the discontinuation of abatacept, the patient showed a flare both at articular and lung level. And so we decided, it seems easier here to interpret the lung deterioration. The simultaneous deterioration or relapse of joint disease activity and pulmonary involvement suggested a correlation between the two, and also an efficacy of abatacept. But due to the recent infection with ABSB, we decided to change mechanism of action and started tocilizumab. Tocilizumab immediately allowed articular and pulmonary stability and remission. Then in the latter, the pulmonary involvement suddenly worsened within 3 years until the patient died due to right heart failure. And here we see the final involvement, pulmonary involvement of these patients with extensive areas of honeycombing associated with bronchitis, chronic bronchitis, and emphysema. What can we say about this new lung deterioration? This is probably the most difficult interpretative case. Initially, tocilizumab seems to control both articular and lung involvement. Then something led to the inexorable advancement of pulmonary involvement. In the last 3 admissions, only once was ABAT performed, but no microorganisms were isolated, and several therapeutic strategies were administered, but nothing could stop the disease progression. It's probably that in this case, numerous causes of lung deterioration may have been involved. An exarticular manifestation of rheumatoid arthritis, drug toxicity, unidentified infection, smoking habits, or a phlogistic process or fibrotic process supported by pathogenetic mechanisms different from the synovial ones. In conclusion, it's helpful to remember that lung involvement is one of the leading causes of death in patients with rheumatoid arthritis. That lung involvement mainly affects patients with autoantibody positive rheumatoid arthritis who smoke. And that whenever there is a lung involvement for its progression, we need to consider, in addition to the underlying disease, several other causes, such as infections, comorbidities, and drug reactions. Thank you.
Thanks, Ludovico. Now we can move to Dr. Bozzalla Cassione, and then a short discussion before to lunch.
So good morning, everybody. Thank you, Professor Cavagna, Professor Eller, for the kind invitation. So we move on to the next clinical case. We're talking about RA-ILD. So we talk about Loredana, a woman, 71 years old. She is a past smoker, a light smoker, 3 packs a year. She stopped back in 1998. She has a cardiovascular history with NSTEMI back in 2009 and cerebral hemorrhage, and of course, arterial hypertension. Her rheumatological history beginning dates back to 2018, when she developed inflammatory arthralgia, swelling of the wrist, painful of wrist, metacarpophalangeal joints, increase in CRP, ESR, and rheumatoid factor was found to be positive, ACPA negative, and the rest of the autoimmune profile was negative. So it was possible to make a diagnosis of rheumatoid arthritis based on the ACR Euler 2010 criteria, and of course, methotrexate was started as the most classical and common approach in this patient. Also at the baseline, she performed chest X-ray that was normal, and a pulmonary function test demonstrated normal airflow rates, lung volumes, and the LCO. Her path, her journey in the rheumatoid arthritis disease history is the most common one. So with a good disease control with methotrexate, loss of a very good disease control. So she needed to increase methotrexate, gaining back good disease control once again. In 2021, she performed another pulmonary function test where again, airflow rates and lung volumes were found to be generally normal. No DLCO was made at this time in 2021. 2021, disease control was good. And at the end, in 2022, she reached out to our hospital for a second opinion since her rheumatoid arthritis was reactivated. Indeed, at that time, it was February 2022, arthritis was present and was very active, hands, wrist, extended morning stiffness, increase in CRP, in ESR, swollen joint count, tender joint count. And at the auscultation of the thorax, we found out some lung freckles, fine freckles at both the lung bases, and a minimal exertional dyspnea was referred by the patient. So at this point, we thought that the best option was the one to start second-line therapy with a B-DMARD to perform a chest X-ray and to repeat pulmonary function test. I remember that the last one was made 2021, so 1 year before most. Unfortunately, she was not able to reach out to the beginning of the B-DMARD therapy because in March 2022, she developed a rapidly progressive dyspnea, malaise, fever, desaturation, and she was admitted to the ER. And this is the chest X-ray picture we found at the beginning. She then performed a CT scan for the first time in her life. And we found out an apical accessualized saccade effusion that you can see in the top left image. A diffuse emphysema at both the apices. I'm sorry, it's not clearly visible in these images, but believe me, it was there. And fibrosing aspects at the bases that were, congruent and consistent with the clinical findings at auscultation. Bronchial viral lavage was performed, was negative, empirical antibiotic therapy was started, and fortunately, she had a progressive improvement and she was dismissed with oxygen therapy, 2 liters per minute at home. After the rehabilitation, she performed a new CT of the lung, and what was found was the picture you see here. So diffuse emphysema at both the apices and a lung fibrosis at the bases. And on the right, you can see a sketch of what CPFE looks like. So in red dots represents the emphysema, and the yellow triangle instead represents the lung fibrosis you can see at both the bases. She performed a new pulmonary function test at that time, was June 2022. Once again, airflow rates and lung volumes are practically normal, while as you can see, DLCO, which was not performed back in 2021, is dramatically reduced. And this is something that makes sense when we think a picture mixing up together emphysema and lung fibrosis, because after a certain point, when we talk about airflow rates, when we talk about lung volumes, restrictive and obstructive disease perfectly counterbalance each other. So we are not able to see any major difference in the pulmonary functions test. But when we move to DLCO instead, both the restrictive and the obstructive aspect, when we are talking about emphysema and ILD, points toward the same direction. So they both give a marked reduction in DLCO, which is what we find in our patient. These are few data not strictly related to CPFE, but is what I managed to find as close as possible. So on the left, you see a graph from the INPULSES, so the original study from nintedanib, not the INBUILD, which was the next one published in 2019. And here you can see the two black lines with the dots in the square, which presents data and the results of nintedanib, the effect of nintedanib in patients with and without emphysema. And you can see that nintedanib in idiopathic pulmonary fibrosis was able to provide the same or almost the same result in both cases. But unfortunately, on the right, you can see instead the outcome in terms of survival of patients with rheumatoid arthritis interstitial lung disease without emphysema, the blue line, and with emphysema, the green line. And you can see how striking the difference is in survival. So unfortunately, that's a fact. Our patient was then started at the end with abatacept for the risk of infection and saccated abscess that was found before. And it was started on nintedanib based on the data I've just shown you. Fortunately enough, our patient in July 2023, she just arrived back to our attention in the past months, had a chest x-ray that was perfectly stable, and also pulmonary function test demonstrated the same results. So these cases just want to point out the fact that it's always very important to request DLCO when we're dealing with rheumatoid arthritis ILD, because CPFE is not the most common, but is presentation that we may encounter, and we are not expecting a restrictive pattern in this patient. And DLCO is the only factor, is the only data that could drive us to perform eventually, even in an asymptomatic patient, a chest X, a lung CT scan, and to find out so that we have this problem. And I think we might have missed the best window of opportunity in this patient, both for the choice of the drug, for a proper monitoring, of course, starting before also eventually an antifibrotic drug. That's all. Thank you for your attention.
Stay here because we have the discussion.
Just to end this session, I would like to ask you, Prof. Joao, Dr. Joao, a question. In practical terms, when, what is it, Doctor? Sorry, I didn't see you. Just because as an expert in the field, just for everybody, and a question that I don't know, you keep in mind at the time of prescribing or a biologic or not in a patient with rheumatoid arthritis. Do you prescribe a biologic depending on the CT scan pattern?
No.
The question was that some people say that maybe in patients with UIP, maybe abatacept is getting better, but we don't know really.
Yeah, I think we don't have evidence to say that we should do a CT scan to our patients. In the mind of most of the pulmonologists that are facing the difficulty of being sure of what should they comment regarding the risk for infections, and particularly tuberculosis, etc. It's quite common. I think you have that experience that they do a CT scan, but they in fact are not thinking on the underlying ILD, etc. And then we get frequently the CT scan prior to the decision. It's not a matter of a systematic approach, but we get very frequently. And based on that, we might have to face the decision what biologic we should choose. But at this moment, there is no indication for it.
Regarding this point, I think I feel that the sooner the better in terms of therapy, no matter what therapy are you using. For example, for the abatacept data that you discussed, the good results, because I knew a little about this data for sure, were related that the pulmonary function test of these patients were not bad, you know. So I think the good results in terms of stable, no progression, was probably related to the less severe functional damage in these patients.
Okay, I think that we can close the session. We will see after planned time, but we will have one change because unfortunately, Professor Raffaele Bruno will not attend at this meeting for a problem. So we will join the person for clinician to the session for in systemic sclerosis, and we will end with the coffee break. So after the coffee break, you can enjoy Pavia. See you later.
Oh, I'm sorry. Dear colleagues, good morning, ormai è un pochino troppo tardi, ma diciamo, it's too late. So it's a great pleasure to continue this meeting today with a session on systemic sclerosis. And as you may see from the program, we have 3 speakers today, as well as a case presentation. And the first speaker will be Professor Dilia Giugioli from the University of Modena, and she will introduce us on systemic sclerosis in the lungs, in particular about the clinical aspects and also the screening. Please, Dilia.
Good evening, everyone. I'd like to thank the organization. Thank you, Professor Matucci, and thank you, Professor Cavagna, and giving us the possibility to focus in this very challenging aspect, systemic sclerosis and the lung. And now we try to summarize what we know on clinics, screening, and finally, even further, personal critical point on sclerodermal lung involvement. Sclerodermal lung involvement in which there are 2 main manifestations, lung disease and pulmonary hypertension, or a combination of both that we know related to a particular poor prognosis of the disease. Now we focus on the first one, lung disease, interstitial lung disease, ILD. This heterogeneous group of lung disease characterized by diffuse involvement of the pulmonary parenchyma with varying degree of inflammation and or fibrosis related to a known cause, IPF, or known causes, drug, occupational, systemic disease, for example, and among systemic disease, connective tissue disease is one of the most common causes of ILD. As reported in this well-known study, where, for example, ILD was present in up to 50% of patients with rheumatoid arthritis, and from 8 to 20% of patients with Sjogren's syndrome, but mild to moderate ILD is detectable in the majority of patients with scleroderma, in about 70–90% of patients. ILD could be the first manifestation and occurs early in the course of systemic sclerosis. As reported in this study, the first one from US registry, 45% of patients with early systemic sclerosis had ILD, and in the second one, ILD was present in up to 10% of patients in the first 5 years of systemic sclerosis. These data are also confirmed by our Italian systemic sclerosis registry, SPRING. I underline here the VEDOS group, so very early systemic sclerosis. Lung involvement was present in 21% of our patients. I'd like also to share with you these interesting data on racial and geographical differences of ILD, and in particular, the USTAR database result on differences among regions in terms of clinical presentation and also prognosis of ILD related to systemic sclerosis. And complicating our understanding on ILD in systemic sclerosis, the concept of progressive pulmonary fibrosis. From the INBUILD trial description to the American Thoracic Society definition that I try to summarize in these 3 points: worsening of respiratory symptoms, physiological and radiological evidence of disease progression within 1 year. Another time, as we can see in the blue area, high proportion of PPF in systemic sclerosis. To date, ILD is still one of the main causes of death in patients with systemic sclerosis. While diagnosing a patient, we have two big challenges. First, the early diagnosis of systemic sclerosis, but also the early diagnosis of lung involvement. Early systemic sclerosis, as reported in this study, is still a significantly confusing area, but also for ILD, despite the relationship between mortality, morbidity, and mortality, we have no consensus on ILD screening, but we need to understand which test should be used during screening and also follow-up when ILD becomes clinically significant in systemic sclerosis and when treatment is indicated. So a standard approach for screening and therapy is essential. But in the unpredictable course of systemic sclerosis and also ILD related to systemic sclerosis, how can we screen our patients with systemic sclerosis? Here, the American Thoracic Society clinical practice guideline for the diagnosis of idiopathic pulmonary fibrosis advises following pulmonary function test, imaging, HRCT, biomarkers, and histopathology. But how to use them and when in a systemic sclerosis? We must bear in mind also the importance of clinics, so require the most common sign and symptom of ILD, fatigue, dyspnea, and cough. Physical examination, very important, with the typically crackles or during lung auscultation. But we know that early ILD is often asymptomatic in systemic sclerosis, and the symptoms are not specific for ILD, reflux, pulmonary arterial hypertension, for example. And even also the role of PFTs is uncertain in the screening of patients with scleroderma, as we can see here. However, this recent study, based on real-life data, confirmed FVC as a robust marker of survival in patients with SCC ILD. Nevertheless, PFTs with HRCT are key element for the screening of patients with systemic sclerosis. CT scan is considered the gold standard for the diagnosis of ILD. And this is confirmed also by the European consensus statement. We can see, no, funziona. Here, screen all patients with systemic sclerosis for ILD using HRCT with the help of pulmonary function test and physical ILD physical examination, suggesting the use of multiple methods for the assessment of ILD severity. In this study, very recent, this study underlying the need, an urgent need for the use of a composite strategy also for the screening of patients with scleroderma. Please see here. And suggesting the use of biomarkers, serological markers, breathomic and radiomics. We know very well the need of a quantitative computed tomography algorithm as a caliper, providing a graded risk score, so risk ILD progression is essential. And the role of lung ultrasound, useful in the screening of ILD in systemic sclerosis, but we need to define the standard protocol and the role of biomarkers used to screen at-risk patients as listed here, and I report some example of inflammatory markers related to ILD. And I'd like also to report the study from Australian group on a composite biomarkers, surfactant protein D, tumoral markers, and ICAM1 strongly associated with ILD in systemic sclerosis. And finally, histopathology. Some interesting data from cryobiopsy in CTD, but we have no data for ILD in systemic sclerosis. And I would like to briefly run through a few future approaches: the use of PET, video capillaroscopy for ILD, the use of UT-MRI, for example, a suggested ILD risk score, very interesting, but obviously we need to implement future investigation. And now I try to report some personal observations, some critical points. For example, the role of ILA incidentally detected in CT scan in patients with scleroderma. We have little evidence in ILD related to scleroderma. And the result of the study from the French group, ILD screening used chest X-ray in 43% of cases and only 29% use CT scan. And also this well-designed study, HRCT was prescribed by 50% of general rheumatologists and 66% of systemic sclerosis expert rheumatologists, underlying a substantial global practice variation. And finally, the multidisciplinary approach. We know that multidisciplinary approach is fundamental, it is essential in the assessment of ILD, not only for scleroderma. Here, a position statement from the Thoracic Society of Australia, for example. But I'd like also to report the result of this study underlying the lack of standardization of MDT in systemic sclerosis. And in conclusion, from the bench to bedside, take-home messages: screen all patients with systemic sclerosis with physical ILD examination, clinics, and screen also for pulmonary hypertension. ILD patients phenotype characterization using multidimensional ILD screening algorithm refer the patients with ILD to scleroderma center where, with multidisciplinary evaluation, a tailored therapy could be prescribed. And I leave you with this quote, very fitting for systemic sclerosis. E grazie a tutti per l'attenzione.
Thank you, Professor Giugeli. We shall have the discussion all together, joint. We should have the discussion joined also with the next presentation, and it's my great pleasure to introduce Professor Dinesh Khanna. Dinesh, can you hear us?
I can hear you well. Good morning, Marco. Good morning, Lorenzo.
Hello, Dinesh. So great pleasure to have you with us. And Professor Khanna is the director of the scleroderma program at the University of Michigan at Ann Arbor. And he will present about systemic sclerosis in the lungs, about issues on therapy. Please, Dinesh.
Thank you very much. So thank you, Marco. Thank you, Lorenzo, for this warm welcome. And I think the first talk was excellent. And I like that Sonia Gandhi was quoted, you know, that's the relationship between India and Italy, right? On Sonia Gandhi. I need access to share my screen. If somebody can give that to me. Okay, I have it now. So hope you can see my screen.
For sure.
Okay, thank you. It is. Let me just try. I apologize. It's pooling here. Doesn't want to. Okay, there we go. Let's see. Okay, sorry about the delay. So again, it's a great honor to be presenting at this very important meeting. And again, thank everybody for inviting me for this presentation. So my talk will focus in 15 minutes on the management of scleroderma ILD. Here are the appropriate disclosures. So I think I want to start by making a statement that scleroderma-related ILD is predominantly fibrotic and SIP, and it's important to understand that compared to what Rohit and others may have presented as a inflammatory myopathy, which is a cellular NSIP, where there's a big role of steroids, there is really no convincing role of moderate to high dose prednisone in the management of systemic sclerosis related interstitial lung disease. So I think that's the first statement I wanted to make because there always seems to be a bit of confusion around this issue. So this is the work that Professor Matucci and others have been quite involved with, Anna Hoffman-Wold. And what I want to highlight, which was highlighted by the previous speaker, is the heterogeneity. So we know that 50 to 70% of scleroderma patients will have ILD. Majority of the ILD occurs earlier in the disease, and majority of the decline occurs in the first 4 to 5 years. You see the first 3 years, and this is a USTAR database, and majority of the significant decline occurs in the first 3 to 5 years. So that poses a challenge for rheumatologists and pulmonologists. Who do you treat and when do you treat and what do you treat these patients with? So in my mind, the concept on the management of scleroderma ILD starts with looking at the patient, looking at the HRCT and PFTs and determining whether the patient requires a pharmacological treatment, whether it's methotrexate, mycophenolate, and tocilizumab or other treatments. And if yes, we tend to treat as rheumatologists, the goal is to treat early scleroderma-related ILD with immunomodulatory therapy. There are very rare cases where I would go to an antifibrotic therapy for early scleroderma-related ILD. The role of antifibrotic therapy in my mind is patient who has progressive pulmonary fibrosis, which may be 15 to 20% in the patients who have scleroderma-related ILD. And although I'm not talking today about it, is there a role of upfront combination therapy in this patient population? So before we talk about the pharmacological management, we should always be aware of the appropriate vaccination, influenza, COVID, pneumovax, oxygen therapy for hypoxemia, pulmonary rehabilitation. We offer it quite often, and we see a big improvement in dyspnea and quality of life, and the management of cough and aspiration. So the treatment over the last 2 decades really has focused on immunosuppressive therapy. So if you ask all the rheumatologists who are attending the meeting today, including Professor Cavagna and Professor Marco Matucci, most of us used to use oral cyclophosphamide or IV cyclophosphamide based on the data from Richard Silver and others that have published. And then there was scleroderma lung study 2 that really promoted the role of mycophenolate mofetil. And in fact, I'll show you the data in US, mycophenolate mofetil is prescribed in 70% of the patients. And then we have tocilizumab, some antifibrotic therapies, and if they have severe progressive ILD, at US we do stem cell transplantation, rituximab, and maybe lung transplantation. And again, just to highlight the significant role of mycophenolate came from scleroderma lung study 2, where patients were randomized to mycophenolate or Cytoxan followed by placebo. And what we showed here was an improvement both in Cytoxan in the bolded line and in mycophenolate over a period of 24 months. And this is the data from a US registry, early scleroderma, 300 patients with a disease duration of only 1.2 years. Majority had scleroderma ILD. So this is a snapshot that I'm giving you how the physicians in US treat. 70%, 68.8% use mycophenolate. 21% use methotrexate. And you can also see that 42% of the patients are treated with low-dose prednisone. So indeed, mycophenolate mofetil has become the treatment of choice for early scleroderma, including systemic sclerosis-related ILD. So this data is quite meaningful as we design clinical trials, as we manage our patients. But unlike the clinical trial data that I showed you out here, over a period of 2 years, there's an improvement. The data looks quite disheartening, quite concerning when you look at these patients followed for over 10 years. And I will focus on the forced vital capacity worsening in patients who had ILD defined by greater than 10% decline. And you can see that patients continue to decline over a period of 8 to 10 years. And by the end of 8 to 10 years, you see about 35% of the patients had developed progressive ILD. So although we tend to use mycophenolate mofetil based on the clinical trial data, when you look at the actual registry and you look at the longer term follow-up, it seems that the patients continue to have a slow progressive ILD, or as our previous speaker defined, progressive pulmonary fibrosis. So that's one thing that I would like to highlight. Mycophenolate may be effective for the first 1 to 2 years, but the effect seems to wane off after that. The other thing I want to highlight is that mycophenolate and cyclophosphamide have never shown to have any impact on morbidity and mortality. And there's no data to support the duration of therapy. We tend to give a longer term therapy, at least for 10 years. And I always talk to the patients if they want me to taper it, that there's a 15 to 20% risk of flare with the ILD and with the skin involvement. So it's a longer term, maybe lifelong therapy. So let me focus very quickly on 3 therapies that I think every rheumatologist should know. The first one is rituximab. It's a B-cell depleting therapy, and we are all very aware of rituximab. And this is a randomized controlled trial done by Toby Maher and the colleagues in United Kingdom, where they took patients with scleroderma, inflammatory myopathy, or mixed connective tissue disease. And these are treatment-naive patients. So it's a new patient that is coming to you with ILD, and they randomize the patient to monthly cyclophosphamide or 2 doses of rituximab, 1,000 milligrams 2 times. 38% of the patients had ILD, and the comparator was Cytoxan. So who are the patients? And as we heard from previous speakers, I think the diagnosis is delayed quite a bit, but you can see majority of the patients were inflammatory myopathy, followed by scleroderma, followed by mixed connective tissue disease. And having an earlier disease duration of 4.8 years, you can see that majority of the patient had a FVC of 71%, a diffusion capacity of 40%. So I would consider that as a moderate restriction, and our goal as rheumatologists to capture these patients early. Both cytoxin and rituximab, like what we showed in scleroderma lung study 1 and 2, had an improvement in forced vital capacity over a period of 6 months that was maintained over 48 months, and rituximab was much better tolerated. So here's a study showing that rituximab may be effective as a first-line therapy for connective tissue disease-associated ILD, including scleroderma. And in scleroderma, as we have seen, there was stabilization and inflammatory myopathy being more of a cellular NSIP. There was actually improvement in the forced vital capacity over a period of 48 weeks. And then, of course, we have tocilizumab. You know, this is a study that looked at targeting interleukin-6 using an interleukin-6 receptor antagonist in patients who had elevated acute phase reactants and early systemic sclerosis. Now, I want to make 2 or 3 very, very key points out here. What we want to do as rheumatologists is to treat patients who have earlier disease, stable, very mild, or normal pulmonary physiology. And you can see majority of the patients in this trial who had ILD, which was 68%, had anti-topoisomerase antibody. So patients who had anti-topoisomerase antibody or anti-scleroderma 70 tend to likely have earlier ILD and more progressive ILD. So here are a few comments I want to make. 67% of the patients, if you take early diffuse scleroderma with elevated acute phase reactants, will have underlying interstitial lung disease. And for educational purposes, diffuse scleroderma, elevated acute phase reactants, and positivity of anti-scleroderma 70. These are the patients that I'm very aggressive, and I don't wait for the lung function to decline below 80% or so before I start treatment. 30% of these patients, when they came into the trial, were not diagnosed with ILD. So you can imagine a large minority of the patients are not diagnosed, and 30% of the patient had moderate to severe ILD. So, you know, these are the patients moderate to severe ILD, and it's important to highlight that early systemic sclerosis doesn't mean that you have mild ILD. 1 in 3 patients had moderate to severe ILD. And there were 2 key lessons that I learned from this trial. Number 1, that if you take the patient in an acute inflammatory phase, there's a very large decline in the placebo group, approximately 10 times that what you would expect in general population. And tocilizumab was highly effective in preserving lung function over a period of 1 year. So those are 2 key lessons. In the right patient, selected patient population, tocilizumab has a very large clinically meaningful effect. And then, of course, we have nintedanib, which is a tyrosine kinase inhibitor. And nintedanib, unlike rituximab and tocilizumab, are done in a real-life cohort where 50% of the patients were diffuse scleroderma, and they had abnormal forced vital capacity and quite a bit of fibrosis, tend to attenuate the decline. So it does not preserve the lung function, but it slows the decline of lung function. And the effect seems to be much better when you're taking mycophenolate as a background versus not taking mycophenolate. And I think this is very important data. If you are come on mycophenolate as a background, the decline in placebo was 60 ml compared to 120 ml if you were not on any placebo at all. So this is another data supporting mycophenolate, but unlike the scleroderma lung study 2 data where there was an improvement in mycophenolate, this really validates the data from our US registry, where if you are on long-term mycophenolate, the effect tends to go away over time. So why is that? You know, this is our cohort at University of Michigan who have scleroderma ILD. And there are 2 key points I would like to highlight here. All of these have ILD on HRCT, but you can see 40% of our patients have normal forced vital capacity, quote unquote, anywhere from 80 to 120%. And then you can see if you look at the cohort overall over a period of 120 months or 10 years, you see on average people don't change, but on spaghetti plot, there's quite a bit of variability that happens. And then there are patients like this who have a precipitous decline over the 1 year, and then they stabilize. So I would like you to think of scleroderma ILD as an early immunoinflammatory driven phase where your rituximab, where your mycophenolate, tocilizumab, Cytoxan are quite effective, and then a more fibrotic-driven indolent phase where the effect of immunosuppressive therapies goes away, and we are more reliant on anti-fibrotic therapies. So here's my last slide. I'm looking at the time. I still have about 2 minutes. So my approach to treating ILD. The first line therapy, I would like to have a discussion and discuss with my colleagues in Italy and also on YouTube. Majority of the patients, we tend to go towards mycophenolate mofetil. If they have elevated acute phase reactants, if they have scleroderma 70 antibody or inflammatory arthritis, you can go to tocilizumab. And if they prefer IV infusion, then the rituximab would be the preference. There is no role of moderate to high dose prednisone. I want to emphasize this part in a fibrotic NSIP. There's never shown, although I see all around the world, that this is used quite a bit for managing early scleroderma related. Progressive ILD subtype, I used to always say that majority of the patients do really well on mycophenolate, but as I look at the data, mycophenolate effect goes away after 3 to 5 years and people start to have more progressive ILD. You have choices of adding nintedanib, which has been shown in a very large clinical trial. You can add other immunosuppressive therapies such as tocilizumab, rituximab, or replace, or autologous stem cell transplantation. And soon with my colleagues in Italy and other places, we are bringing CAR T therapy as a treatment option in a clinical trial. And just remember the treatment is long-term and there's a risk of flare in 20% if therapy is stopped early. So just to summarize, people ask me all the time, where do you use tocilizumab? For me, early scleroderma patient with elevated acute phase reactants, I also added progressive skin disease, positive topo antibody, and then patients who have failed mycophenolate. And the nintedanib is really 90% of our patients are progressive ILD on mycophenolate. You could argue the previous speaker talked about the inbuilt inclusion criteria where majority of the patients were UIP or patients who have recurrent infections on mycophenolate and are unable to tolerate immunosuppressive therapy. So with this, I thank my colleagues, my friends who are sitting in Pavia in this beautiful place. So thank you very much, and I look forward to question and answers.
Thank you very much, Dinesh, for a very clear presentation. So you're also presenting now at the end, which is your point of view for the progression and the other early patients. So thank you for providing us also your personal view deriving from your data. And so this presentation as well as the first one are open to questions. Are there any questions coming from the auditorium? Please, Roberto.
Danish, thank you. Roberto Giacomelli from Rome. I just want to know your opinion. I know very well your experience in clinimetrics and in the design of clinical trials. So I have some issue about to derive helpful information from a study like Recital. It is a basket trial in which there are different, that is a basket trial in which you can put together two totally different interstitial lung diseases, such as the interstitial lung disease associated to myositis and scleroderma. And in the recital, it's not clear what kind of definition of progression has been used in the selection of patients treated. We don't know if they were early progressive or not. So derives strong information about rituximab that probably could be helpful, probably need some stronger data within a specific design trial, because one of the limits is that if the study are not designed to define the therapy for a specific type of interstitial lung disease, we could have some misconfounding data. So maybe we could use a drug that could work in some patients, but not working in others. And probably we should better define the patients before designing the trial. I know how long you studied this problem, so I would like to know your opinion about the future trials, the design of the future trials in scleroderma lung disease.
Yeah, thank you, Roberto. Very good to see you again. So I think you are right. You know, the basket trials have concerns and limitations, but this was a very pragmatic trial. In other words, they wanted to take all the patients with newly diagnosed ILD, and you can see that the diagnosis of ILD is quite poor, despite having a disease duration of about 4.5 years. On average, patients had a lung function of 70%, FVC and DLC of 40%. That's not what we want to see. So the first thing in the trial design is to capture early patients with scleroderma at risk. And I think the work that Marco has done over the last decade on VDOS, that's a kind of approach that we need for CTD ILD trials, especially scleroderma ILD trials. We did that with the tocilizumab, but we can even go a little bit earlier to treat these patients. I just want to defend rituximab because I only had 15 minutes. There are now 3 trials of rituximab. This one, the data from Japan, and then there's a trial from India that nobody quotes where they took patients with anti-topoisomerase diffuse scleroderma treatment naive and gave them rituximab or Cytoxin, 60-patient trial done in Calcutta, India, and showed a remarkable and robust improvement in the skin and also in the lung function. So those are 3 trials, but the future trial designs to me is prevention or very early treatment, not treating patients when their DLCO is 40%. I think we have lost a lot of lung function in this patient population.
Thank you, Dinesh. We have a next question, please.
Hey, Dinesh. This is Keith Mitri from Alexion. Thank you for your contribution, and I wish you were here to enjoy this place with us. Thank you for the presentation as well. So one of the things I think that came up a lot in the talks is about, the ILD could be more fibrotic or inflammatory, and we know a lot of the drugs that are available, they're not really approved to be used together. So, but is there maybe, in your opinion, like a chance for like a dual mechanism drug? Is it really always one or the other, or is there maybe the 2 mechanisms ongoing? And with also some of the registries that you also lead, is there any benefit long-term on survival from certain, maybe not as like drugs that you don't think about?
So thank you, good to see you. So I think this is an evolving field, so I'll make 2 or 3 comments. The first one is that monotherapy, and Marco and Lorenzo, please add to it. I don't believe that mycophenolate or Cytoxin or a single drug has any impact on the morbidity and mortality of the disease. So, that's my first observation over the last 20 years. The only therapy that has a long-lasting impact on ILD and mortality is autologous stem cell transplantation. So we do offer that as a treatment. We did a scleroderma lung study 3 with upfront pirfenidone and mycophenolate combination. It was really underpowered, that showed some trends, but really you cannot make any conclusive. I think the future of scleroderma ILD or connective tissue disease ILD for that matter is combination therapies. And you're targeting different aspects, and there are new molecules now targeting B and T cells, simultaneously along with antifibrotics. So as a community, we really need to think about upfront combination therapies targeting the appropriate pathways. What scleroderma lung study 3 showed again, it was only 50 patients randomized 1:1 to upfront pirfenidone, mycophenolate or mycophenolate alone, that majority of the patients on upfront combination had no progression in their ILD on HRCT quantification at 18 months. Whereas patients on mycophenolate, although they showed an improvement in lung function, on their HRCT, they had continuing progression of their fibrotic ILD. So I think what we are seeing with these therapies is that it gives us a false hope for 2 to 3 years on mycophenolate, but the effect wanes off after that.
Thank you very much indeed, Dinesh. This speedy and very clear answer. Do we have any other question? Another question also for the first talk.
Any question for the first talk?
Well, I have a question for the first talk, if I may. I think it was an excellent presentation. And my question is, should we be doing HRCT in every patient? I showed you with the recital data that majority of the patients, and Lorenzo, this is a question for you too. When Rohit and I talk about our patients, all our scleroderma patients get a baseline HRCT. And I want to know whether the patients have ILD or not. Do you agree with that? Every scleroderma patient should get HRCT, and the same question for inflammatory myopathy.
So I'm sorry, Dinesh, because probably we missed some of your part. Can you just again tell us which is the question for the first talk? I'm sorry.
Should HRCT be done in every patient with scleroderma and inflammatory myopathy when we see them for the first time?
Thank you, Professor Canna, and thank you very much for your presentation. And in our experience, we suggest to do chassis array for this at baseline for all patients, because it's important also for other manifestation of systemic sclerosis, pulmonary arterial hypertension, for example, and the differential diagnosis. We're waiting for the use of lung ultrasound, but obviously only some center could be lung ultrasound for scleroderma patients. So there's an urgent need to the standardization of lung ultrasound. And also the dual energy CT scan, for example, and very important. And but we suggest to use the CT scan in patients at baseline, because scleroderma patients at risk patients.
So practically, Dinesh, is the same protocol you have. So we are applying for screening in the early patients, and in every patient that comes into the clinic, the CT scanning as a first line baseline assessment practically. So Lorenzo, can you also give us your point of view from the myopathies?
We are following the same schema as in scleroderma patients, because all patients with myositis perform CT scan. First of all, because of the identification of interstitial lung disease, but then also as a screening, for example, also for patients with necrotizing myopathy to rule out maybe an hidden neoplasm. So we are performing at least a baseline to CT scan. Then according to autoantibody, maybe that we can repeat 1 year after, or maybe that we could slower to check, as for example, for a patient with myopathy, statin-related myopathy, that it could be enough once a time. But it's in our daily practice, the assessment of lung.
So I think as our audience listens to that and look at the data, the patients who were recruited in Sensis nintedanib trial and also for the recital trial, I think one thing is very clear that most of the rheumatologists don't do that. Because when you look at the patients who are recruited in these trials, they already have a significant decline in their lung function by the time they come for treatment and clinical trials. So I think our role as rheumatologists is really to push towards doing a CT in the appropriate patient population. And the new guidelines from the ACR that will be presenting at the ACR in November for ILD will also advocate this.
Thanks a lot. I think that we can end this discussion. Dinesh, I'm very happy. I'm proud to have you as a speaker, even if not in Pavia, but I really hope that next year you could reach us in the next Congress that will be performed in the same period with the same weather. I really hope. So I end the discussion. You are free, or you can have the chance to hear Veronica Codullo that works with me, and she's talking about veno-occlusive disease in systemic sclerosis.
Thank you. Thank you very much.
Thank you.
Bye-bye.
Bye. Good afternoon, dear colleagues. Thanks a lot for the invitation, Lorenzo. It's a pleasure to be here in this wonderful venue. As already mentioned, my topic is about the approach to veno-occlusive disease in systemic sclerosis. This is the outline of my presentation. What is PVOD, first of all? It is a rare form of pulmonary hypertension, which is now referred together with pulmonary capillary hemangiomatosis as diseases of the same spectrum. It affects specifically the venules, the pulmonary venules with a fibroproliferative disorder, which is also, we have to remind this very clearly to understand the pathology, the capillary end and the arterial end of the pulmonary circulation. And this is why PVOD is a great interest in pH classification. It keeps changing, being kicked out and welcomed back in the group 1, sorry about the shoulders, in group 1 pH classification. This is the most recent one. You see it has a specific definition to be distinguished by the idiopathic forms, especially those associated with connective tissue diseases. But we are going to get a more deeper insight into this. Why do we define it among the group 1 diseases? Because it shows a precapillary feature. This is the new classification. Patients show a mean PIP of about 20 millimeters of mercury. Wedge pressure is below 15, the cutoff point to distinguish from post-capillary pulmonary hypertension, despite affecting the venules, as I mentioned, and PVR. This is changed from this publication, but I really liked the color matches. So it's above 2 wedge Wood units. To distinguish the two forms of most important classification, pre-capillary and post-capillary, please take into consideration the wedge, which is above 15 in post-capillary forms. This is also the pathology, the plexiform lesions that are specific to the idiopathic form of pulmonary arterial hypertension and that we never find in pulmonary veno-occlusive disease. Why pulmonary veno-occlusive disease, despite being a disease of the venules, as we just saw, it is a precapillary hemodynamic condition? Because basically we make mistakes when we measure wedge pressure, which is an indirect measure of the venous system. But those venules that we measure are the higher distal part of the venous. The diameter is above the one that in the system is affected by lesions, the fibroproliferative lesion of veno-occlusive disease. And this is why we are tricked by this disease, and also because the relative contribution of arteriolar, capillary, and venular hypertension is something very, very difficult to intercept. Especially, it depends also on the hydrostatic status of the patient, which is, of course, one factor to consider when we are performing the right heart cath and defining our patients. So, therefore, we have revealed the trick behind veno-occlusive disease. It is very rare. There is a genetic form associated to this biallelic mutation in a cytosolic protein. It is genetic, so we know their hereditary forms because of the history of the patient, and these are subjects that need to be screened during their lifetime. They generally are males in their 20s, but there are also sporadic, idiopathic veno-occlusive diseases, and also that's the reason why we talk about this today. It's because the veno-occlusive disease can be associated and in a rather frequent association with connective tissue diseases, and I might say systemic sclerosis is the leader of this group of diseases. We need to remind that veno-occlusive disease can also be iatrogenic, can be caused by use of alkylating agents, and I'm going to mention cyclophosphamide because we know this the diffuse use that we used to. Sorry about the repeating of use, but it is an agent which has been associated, and also autologous stem cell transplant recipients are at risk of developing veno-occlusive disease. So therefore we need to inform our colleagues that are managing pulmonary hypertension. These are very close associations. It is very difficult to diagnose veno-occlusive disease. Except maybe the genetic form, we have a test and we can undergo the treatment or the assessments. It is a challenge because of the nature of the disease. It is a rare form that can be misclassified and can undergo a very late diagnosis. And also there is no diagnostic test that we can perform because it's histology that can clarify the disease, and histology is very rare in the setting of pulmonary hypertension because of the risk it bears in terms of lung biopsy and also the patient's conditions. This is one of the diseases that is a candidate disease to immediate listing or evaluation for lung transplantation. So it is very important to be precise and to be rapid into the identification of screening subjects. But I think this is pointed out from the guidelines, the recent one from 2022, and I believe we are going to listen to more of this in detail in the next two topics. So this is what happens in the lungs. You see arterial fibrointimal hyperplasia. You see the venular compartments, which are also extremely proliferative. And this is, as I mentioned, the diagnostic hallmark of PVOD. And you see also capillary engorgement, capillary proliferation. That's why pulmonary capillary hemangiomatosis is regarded as a form of PVOD. And you see the spatial relationship between the three elements of the circulation. What is this? This is an autopsy of a patient of ours that unfortunately died. And can we really rely on this to make the diagnosis? Of course not. We don't want that. It is the end stage of our effort. So what can be used as a surrogate HRCT, which also in other conditions, as for example, interstitial lung disease, is very, very reproducible in terms of pathology. So if you don't have lung biopsy experts, of course. So this is the mainstay of the disease, of the diagnosis for this disease. And it is characterized by a typical triad that are mirroring the pathology in the lungs. The first sign is thickening, a smooth thickening, because it's the venules that are engorged of this in the septal lines. What happens when capillary are engorged? They leak. So you can see centrilobular ground glass alteration, which are not to be confused with the ground glass alteration that we heard yesterday from Professor Romei, are typical of NSIP features. And as a consequence of the engorgement of the liquid fluid accumulation, we have the third sign, which is mediastinal lymph node enlargement. This is the triad. When we have the three signs, we know we can be quite confident. We can at least suspect this form. This is not always the case. Patients don't always show the three signs, but we are going to see that we can make assumptions quite reliably on our HRCT findings. So why do we speak about PVOD in a scleroderma session at a lung congress? It is one of the forms where pulmonary veno-occlusive disease may occur, and it is a bit more frequent than in the general population. It is, I believe, also quite underestimated, and I'm going to tell you my personal view, and it's this is not supported by literature, unfortunately, because of the rarity of the disease and also the paucity of data, histological data. But is it so surprising? I don't really believe so. You see a capillaroscopy here, and you see there is just not the arterial side that is affected, that is engorged, that is dilated, that is pathologic. You see the terminal end of the capillaries affected. And I think to a certain extent, basically all scleroderma patients might undergo this variation, this pathology, and it depends on the proportion that the lesions are affected that we might suspect PVOD in our subject. This is very important to do because, of course, it has prognostic and, as we see here, impact. This is one of the two main studies of PVOD in a North American cohort. The referral center, in this case, it was Pittsburgh. They analyzed retrospectively the HRCT of their patients, and they went to apply the triad criteria to their patients, where available, of course, and bear this in mind, it is a retrospective study. They found a very high proportion of patients within the pulmonary arterial hypertension patients who showed at least two signs of PVOD. It could be a combination of the capillary engorgement, the centrilobular ground glass. And what characterized these patients? Something that is reflected in the clinic as well. These are very, very severe patients, more frequently than the others, who show a similar hemodynamic, more symptomatic, more frequently in NIA3 class. They walk less. They are more affected at a functional level. They are more frequently already at presentation hypoxic. They need a high oxygen, a high level of oxygen supplementation. And the fourth hint that can lead you to suspect PVOD in a pulmonary hypertension patient is that they develop pulmonary edema when we try to treat those patients correctly, because they tick all the boxes. They are pulmonary arterial hypertension patients, so they need to be treated because we know this is a fatal disease. And I was mentioning it has a prognostic relevance because look at the points, look at the curve here. More than 2 signs of PVOD on an HRCT at baseline bears a very ominous prognosis. Patients die at 45 months of follow-up, and this is a medical emergency then. This is the other study from the other side of the ocean, UK, the center, Jerry Coglan Center in London. They did the same thing, a retrospective analysis. They pointed out that they could find at least one pulmonary vein-occlusive disease feature in 66% of their patients. The combination was different. Numbers were lower, so they found 10%, whereas the percentage was up to 40% in the other study. But they reached the same conclusion. Numbers are small, so they couldn't show any specific feature, although those that I pointed out before are valid also in this study. But unfortunately, they confirmed the unfavorable prognosis of these patients. And the other thing, they tried to analyze if there was a specific class of drugs that could induce pulmonary edema, just to drive a little bit the therapeutic approach. And they couldn't find a specific association of endothelin receptor antagonist or PDE5 inhibitors in this population. Patients developed pulmonary edema, whether on both oral drugs. So does it mean we cannot treat these patients? Well, I already mentioned, the moment you make this diagnosis in your patient and you are quite sure about this complication, if the patient is eligible, you call your pulmonologist and you evaluate the patient for lung transplantation. Again, if possible, if it's a feasible opportunity for the patient. But careful treatment off-label, I should mention this, but careful treatment, and I think this is the view where I see putting pulmonary vein-occlusive disease in group 1, is that we can try to treat these patients. These are patients who still require monotherapy. It's just one possibility when we diagnose arterial hypertension, pulmonary arterial hypertension in this cohort, that when we suspect cardiopulmonary complications, then we should be a bit more careful, less aggressive than we should be according to guidelines in the patients that are at risk of developing complications. So this is one indication for monotherapy, but also, as I mentioned, it's an indication to refer these patients at an expert center, because this is a very nice study, I think, the only study showing that in patients in active lung transplant list, epoprostenol can be used as a bridge therapy in these patients. And as I said, I just said before, they develop pulmonary edema with specific therapy, but it's not always the case. It's not always like that when you are careful, especially in the balance of the hydric balance of the patient. And if you can manage the drugs, you see here, there are the curves of titration of epoprostenol. It is a very low dose and it is a very slow titration curve. But the reassuring message from this cohort, which is very small, of course, but that's what we can have in a rare disease, is that cardiac index is improving in these patients. And I remember, and I want to stress that this is an active listing population. They are waiting. There's a bridge to lung transplantation. Therefore, there's an age selection, of course, in this cohort. But you also see biomarkers are improving a little, which is reassuring. I'm not saying that epoprostenol should be licensed for PVOD, but I should manage and pinpoint the fact that in expert center, there are options. So that's why PVOD should be managed in these centers. So what are the hints? Just to summarize, I haven't spoken about echocardiography because beside the role in screening in general for pulmonary hypertension, there is no specific feature of echocardiography that can be suspicious for veno-occlusive disease. So we cannot spare ourselves the effort of screening our patients with plenty of multi-parametric examination, which is also, in this case, including a genetic counseling for the patients. It is not the mutation of EIFK2K4 biallelic mutation has not been associated to PVOD in scleroderma, but who knows if we analyze carefully our patients, if other association might be found, especially in patients with a very well defined disease as the scleroderma. So we have to use a combination of pulmonary function tests, and pulmonary function tests are absolutely normal in terms of volumes, static and dynamic, but this patient presents with a very, very low DLCO since the beginning, since the start. If you go and see the charts of your patients, you see that already a diagnosis, even before suspecting pulmonary hypertension per se, these are patients with very low DLCO, and this is because their pulmonary circulation, distal pulmonary circulation, is pathologic since the beginning. So the last few points that I want to stress is that if you suspect PVOD, when you ask your cardiologist, of course, we rheumatologists, we don't perform a right heart cath, and we need this discussion with the cardiologists, of course, which are those who are performing the screening for us. So there is a multidisciplinary exchange all the time. But when you suspect this, please remember to avoid acute vasoreactivity testing, because it's not so dangerous, but it might lead to prescription of calcium inhibitors, which are fatal in this condition for the reasons we just see, that the preferential response of the arterial side might lead to pulmonary edema because it does not parallel the exact same dilation in the venular compartment. So this is not recommended. And this is just, and then it's the only caveat in right heart cath. And finally, this slide is just helpful for me to remind that there's also bronchoscopy if the patient is stable, is not too hypoxic, is not too end stage. Valve fluid examination is very, very informative because of the engorgement and the leakage of fluid and erythrocytes. We can find a quite relevant percentage of PERS positive alveolar macrophages in the bowel fluid, which is another hint that can be added to the multi-parameters that we are looking for in our patients to diagnose veno-occlusive disease. So just to conclude, I think this is a very rare condition, but it's not to be neglected because it's very, very common in our cohorts, in our scleroderma cohorts, and in connective tissue cohorts in general in the setting of pulmonary hypertension. We need always to remember history, medications, because we see there are lots of interactions that might lead to the diagnosis. And it is important to collaborate with the cardiologist, with the pulmonologist, because lung transplantation is possible, and a connective tissue disease is not per se a contraindication to lung transplantation. But I'm not spending any more words about this. And of course, if we want to use off-label drugs, let's leave it to those who can, who have the means to prescribe and control them. Thank you.
Thanks a lot, Veronica. Now we can move to clinical case presentation. Please, Dr. Lorenzo Bianchessi, you can present your case. And then we will have the discussion, and we will move before the coffee break, because we have one problem, because one speaker could not be present. Professor Raffaele Bruno unfortunately cannot attend. So we will end with Federica Briganti and Giovanni Zanframundo, and then coffee break, and then enjoy Pavia.
Thank you, Professor Cavagna. I'm going to present you a brief clinical case regarding scleroderma-related pulmonary hypertension. Our patient is a woman, 61 years old at the time, without known drug allergies. She is affected by chronic autoimmune thyroiditis and replacement therapy and chronic venous insufficiency. In 2011, at the age of 52, she developed her first rheumatological symptom, Raynaud's phenomenon, and for this reason, she was referred to her first rheumatological evaluation. Physical examination in this occasion revealed sclerodactyly with a modified Rodnan skin score of 4. Nasal capillaroscopy showed a scleroderma pattern active, and the patient was found to be positive for anti-centromer autoantibodies, confirming the diagnosis of limited cutaneous systemic sclerosis. Once that we have a diagnosis, our patient begins a regular follow-up, and as can be seen from a table here, lung volumes remain stable all over the years, and the patient does not develop any dyspnea, but there's a steady decline in the LCO. In 2020, our patient for the first time refers some mild grade of dyspnea, and therefore we decided to repeat the CT scan. Of course, our patient, this is not the first CT scan of our patient. She did one also in 2011 at baseline, 2013 and 2016, which were all negative. But in 2020, we can see that we have mediastinal lymphadenopathy and right ventricular dilation without any sign of significant interstitial lung disease. In this particular subset of patients, due to the increased risk of pulmonary hypertension, echocardiography is relevant. As a matter of fact, we have two indirect signs of pulmonary hypertension here, because we have increased peak tricuspid regurgitation velocity and a reduced pulmonary valve acceleration time. PVT is defined as the interval between right ventricular ejection and peak velocity. It is normally greater than 130 milliseconds and shortens with increasing pulmonary pressure. According to the 2015 guidelines for the treatment of pulmonary hypertension, which we were using at the time, our patient has a high echocardiographic probability of pulmonary hypertension. And in such cases, there would be a clear indication to proceed with further investigation, and especially with right heart catheterization. But unfortunately, this was not possible in our patient's situation due to the onset of the COVID-19 pandemic. However, our patient condition keeps getting worse with increasing dyspnea, with a weight loss of 12 kilograms in 7 months and increasing BMP. The echocardiography is also worse because we have right ventricular dilation, and the right ventricle is also hypokinetic, and peak TRV is more or less stable. We finally get the patient admitted, and she undergoes right heart catheterization. And as we can see here, we have increased pulmonary vascular resistance with a reduced cardiac index, an increased mean pulmonary artery pressure with a normal post-capillary wedge pressure. When we get all the hemodynamics data together, we get a clear picture of precapillary pulmonary hypertension, and especially of pulmonary arterial hypertension, given the absence of interstitial lung disease and thromboembolism. Again, according to the 2015 guidelines, our patient is at intermediate low risk. So now we have a diagnosis of systemic sclerosis-related pulmonary arterial hypertension. Therefore, the patient was started on tadalafil. We can see at the January 2021 follow-up that we have an initial reduction on pulmonary vascular resistance with a normalized cardiac index, an improvement of mean pulmonary artery pressure with a normal post-capillary wedge pressure, which is important in this particular subset of patients, and especially after specific therapy initiation. However, we observed further clinical and functional decline at October 2021 with worsening dyspnea, increasing BMP, a DLCO of 36%, and at the echocardiography shows systolic flattening of the interventricular septum. Therefore, considering the worsening of the LCO and the echocardiographic findings, it was decided to add unbreathed treatment regimen, which led to a rapid worsening of her clinical status, which was only partially reversible after unprecedented discontinuation. For this reason, we decided to repeat another CT scan, which showed mediastinal lymphadenopathy and right ventricular dilation, which were also present in 2020, but also centrilobar gland gas opacities, and septal thickening without any evidence of thromboembolism. Oops. Okay. Also, the hemodynamics parameters deteriorate. We can see increased PVR, a reduced cardiac index again, and increasing pulmonary artery pressure. The patient, of course, undergoes bronchoalveolar lavage with PERS positivity, indicating the presence of occult alveolar hemorrhage. To summarize, we have DLC of 36%, PERS positivity. We have the typical chest CT triad of septal thickening, central gland gas opacities, and mediastinal lymphadenopathy. We have clinical deterioration after the unprecedented tadalafil combination therapy. Therefore, we can establish a diagnosis of pulmonary vein-occlusive disease. Considering her age, the patient was referred for lung transplantation. As seen just a few minutes ago, PVOD is a clear indication to lung transplantation, given the absence of specific therapy. And our patients in particular has no absolute contraindication to lung transplantation, given the absence of active myocarditis or severe underlying esophageal dysfunction and active non-controlled extrapulmonary manifestations. In conclusion, our patients underwent a successful bilateral lung transplantation in August 2022. She is still alive, so she is fine, and this is her last CT scan from this year. Thank you for your attention.
Thanks a lot, Lorenzo. You can stay here, and Veronica, you can reach us because we are opening the discussion. If there is any question from the audience. I see a lot of experts of pulmonary hypertension. Fabrizio, are you ready for one question? Professor Matucci.
Veronica, first of all, congratulations for challenging yourself with such a terrible experience, clinical experience that we have with POD, that usually is absolutely untreatable. And so can I go back to the diagnosis? So do you think that in our practice, really, CT scanning is allowing us to make the diagnosis? I have to tell you that I have never been able to do this, but this does not mean that you can be able, okay? Because it's so tricky. It's so tricky, and usually, I have to tell you that we rely only on catheterization. So in order to make the diagnosis, I ask the cardiologist to do it, because through the CT scanning, and I use the Bologna guys mainly to do this, I have really difficulty. So that's the reason why the catheterization is giving us the final cut and tell us this is the PVOD and these are your possibilities for the future. So what do you think? Really, you think that CT scanning, it's for us rheumatologists? I just look at the CT scanning and do you think I can, okay? It's really what you think?
No, right heart cath is the method of diagnosing a pulmonary hypertension, the physiologic condition of pulmonary hypertension. And by right heart cath measures, we can define breath,
sorry,
post-capillary.
just because, you know, this is what I wanted to hear from you. So first of all, we have the suspicion, only suspicion.
But we are speaking about, my talk was intended in a pulmonary hypertension diagnosis already established. PVOD is a pulmonary hypertension condition. It is precapillary for the reasons that I explained. And by right heart cath, it is very difficult to distinguish precapillary conditions in general. So group 1 versus group 3, sometimes even versus group 2, because sometimes we have to perform a fluid challenges, we have to perform dobutamine tests to really classify our patients with cardiopulmonary complications. Pulmonary hypertension is not a disease per se, it's a physiologic state. When you need to put your patients in a category, that's where HRCT, pulmonary function tests, this history of your patient come into the picture. And there you can really establish what is the diagnosis, because you cannot treat patients outside group 1 and now group 3 with labeled drugs.
You are meaning that, first of all, we make the diagnosis PAH?
By right heart cath.
PH, and okay. But in your experience, do your cardiologists can tell you directly when they catheterize that this is a PVOD or not?
No, not by PVOD, no. They don't recognize it, and they rely on me. If it's a scleroderma patient, they rely on my colleague Adele Valentini, which is our dedicated thoracic radiologist. All the patients suspected having pulmonary hypertension undergo a list of exams, including HRCT. Bowel examination is not a routine assessment in patients. We do it only if we really suspect PVOD. We don't perform a bowel bronchoscopy in our patients with pulmonary hypertension.
So you suspect PVOD when the patient is not responding to any treatment?
No. Sometimes I do already sniff PVOD before treatment.
I'm sorry to nail you down. Yes. Sniff what?
Hypoxic state, cyanotic patients, DLCO below 50% since the beginning. I have the chance of following a chronic disease. Well, I don't know if it's a chance, depends on your point of view, but I don't have a cross-sectional picture. I have a longitudinal picture. So I know where my patient is going. I can see his hands, I can see the features, I can see where is he going. I can diagnose only after right heart cath, but classification is another effort, a further effort.
I
don't know if I answered your...
I think that we have two ghosts in the rheumatology setting of lung diseases. One is the PVOD, because unfortunately, in several cases, we made the diagnosis after two problems related to increase of the treatment. Is in the majority of cases in the real world, that this is the reason why we can do the diagnosis, because the patient fall down, they will not breathe, he is completely out of control in the majority of cases. I think that we could have to smell, and I don't like this term, but it's true. It's true because we have not a certainty to do the diagnosis. We can try. It is one of the features where we should improve. The other one is the combined pulmonary fibrosis and emphysema. This is the second ghost I think we should deal with in next year. It's difficult. We have a lot of black areas where you should take our attention to improve. This is one of the most important, in my opinion.
PVOD is for sure the worst one, the worst scenario we are facing in practice. And it's so difficult. I have to tell you, it's so difficult. And if you look at medicine, there is another condition that is practically the same, but it's not in the lung, but it's in the liver.
Yes.
And so there is a huge difference of the outcome that we obtain in the liver in respect to the lung. So in the lung, we are forced to transplant, while in the liver, we can treat.
Yes, there's
so,
just one drug.
The difference is so striking in practice. And sometimes I cannot understand why in the lung it is so difficult, in the liver it's so easy. No, I mean, not easy.
Well,
I mean, it's much easier.
There's
Not
at
always,
least one.
not always, but
Yes.
they have a possibility that we don't have in PVOD in the lab.
Because we arrive very late.
So that's a
Diagnosis.
problem.
I want to be provocative, but PVOD is an histological condition, but we are not allowed to biopsy our patient because of a diagnosis of scleroderma. It's not ethical. But my point in showing you the autopsy was to show that these lesions are there when they are affecting primarily the arterial compartment. Then you have the hypertensive state, but you don't need to be hypertensive to have veno-occlusive disease. Ideally, if the patient is well compensated, it's in a very nice hemodynamic state, and you don't overflow the venues.
So what you have said now,
Yes.
sorry, it's very important for everybody's listening today, because you have told us that it's not necessary to be hypertensive to have PVOD already in act.
Yes,
Okay,
because
so but this is making our life almost very difficult because we know that you are developing already PVOD, but you don't have any sign of, I mean,
there is a second hit.
We sniff, as you said, we sniff, but still we don't have really the demonstration that this patient is increasing the pressure in the precapillary area.
It can be compensated. And
absolutely, it can be compensated. So
you don't
this is a
perform
trick.
a right heart cath every
Actually,
day.
a trap.
Of course.
Sorry, this is a trap. We fall down and we lose the momentum. We miss the momentum.
Sometimes we are on time. Sometimes, but very rarely. I've seen many patients dying, and we have shared many decisions of asking for an autopsy just to learn from our mistakes, from a loss of opportunities. But I say just PVOD is just in the picture, and we must not forget it if we have to deal with scleroderma.
To remember for sure. I think that
thank you very much.
Have you any question for Lorenzo? In my opinion, he explained it perfectly with that description of a patient what Veronica reported. So, in my opinion, we can end this session, and now I'm inviting Professor Carlo Scire and Professor Luppi for the introduction to the last session.
First of all, I would like to thank Professor. I can start. Good afternoon. First of all, it is a real pleasure to be here, and I would like to thank Professor Lorenzo Cavagna for the very kind invitation, and also on behalf of my co-chairman, Professor Carlo Alberto Scire. We are both from the University of Milano Bicocca. We are going to start this section inviting Dr. Federica Briganti from Pavia, and the title of her presentation is Patient Selection for Lung Transplantation, How to Deal with Rheumatic Diseases.
First of all, I would like to thank Lorenzo for the invitation. And I must confess that I'm excited to talk about lung transplantation in front of my mentor, Professor Meloni. And then as I think a few pneumologists are here. I think I will be the only one today not talking about lung involvement. So lung transplantation is a life-saving procedure. And although in these years, the number of lung transplants is increasing, there is today a shortage of organ. So when we list a patient for transplant, we need to make the medical choice, but also an ethical choice, because survival must be maximized and candidates should be carefully selected, because when you do an unsuccessful lung transplantation, this impacts not only on the patient who gets transplanted, but also on a potential recipient who did not get the organ. So how can we do to select the appropriate candidate? ISHLT, the International Society for Heart and Lung Transplantation, gave us some suggestions. So there are 17 absolute contraindication, of which I would like to notice the last one. So severe uncontrolled medical condition expected to limit its survival after lung transplantation. And then 21 higher risk factors, among which severe esophageal dysmotility, since we are talking about rheumatologic patients, this is very important. And 24 minor risk factors, among which connective tissue disease is one of them. Scleroderma, lupus, and inflammatory myopathies are a risk factor in lung transplantation, and also severe gastroesophageal reflux disease and esophageal dysmotility. Multiple studies have done in these years, and they demonstrated that the survival after lung transplantation in patients with connective tissue disease is the same with the patient with IPF and other indication for lung transplantation. But this will happen if we carefully selected patients for transplantation. In these Chinese studies, for example, they show that the survival after lung transplantation in patients with interstitial lung disease with connective tissue disease is the same that of patients with IPF. On the contrary, in this Spanish study, patient with CTLD is reduced compared to patient with IPF, probably because of the selection of candidates. In fact, in another study from the US, patient with non-scleroderma connective tissue related interstitial lung disease has the same survival as patient with IPF, but these are patients highly selected. They were screened for extrapulmonary comorbidities. And also, in this French study, looking at the scleroderma patient, the survival is similar between patient with scleroderma and patient with other indication for lung transplantation, except for female sex in association with pulmonary arterial hypertension, where they had a lower survival. Finally, I think we already saw this study in idiopathic inflammatory myositis. This is a core study from a European group. This idiopathic inflammatory myositis should not be considered as a contraindication to lung candidacy. In fact, the global survival it's similar, but you should look at the muscle involvement carefully. In fact, patients with classical IIM have a worse survival compared to amyopathic form. So what is the actual figures? The actual figures in the registry from 2019 for ISHLT, patients who get transplanted for CTLD are only 0.9% among all the other patients, of which almost a third were transplanted for rheumatoid arthritis lung disease and 21% for undifferentiated connective tissue disease. What is remarked on all the studies is that the need for a multidisciplinary team and the evaluation of the specific extrapulmonary complication in all the different connective tissue disease. So in 2001, ISHLT, in order to help clinicians to evaluate patients with connective tissue disease, made this consensus document about the selection, the operatory and surgical problem, and the management post-transplantation specific for the patient with interstitial lung disease in connective tissue disease. This is divided in 3 parts. The first part is on the selection of the candidates. The second part is the surgical part, and it's dedicated to the surgeon. And the third part is dedicated to the management of the disease after the transplantation. Going to look at the first part of this consensus, what are the specific issues connected to connective tissue disease? So we should look at the extrapulmonary involvement risk factors of the timing, because time is essential, as we already just heard about the PVOD, and the pre-treatment strategies, which are very important and we'll talk about later. So going to see all the disease. Starting with systemic sclerosis, which are the lung involvement that are susceptible of lung transplantation. For, of course, ILD, both NSIP and UIP, pulmonary hypertension, combined interstitial lung disease and pulmonary hypertension, pulmonary fibrinostosis, and shrinking lung syndrome, which I will discuss later. So in ISHLT, propose a classification of candidates, of lung transplant candidate in 3 classes based on the findings on the HRCT of the thorax and the extent of the interstitial lung disease, and the hemodynamic profile on the right heart cath. So we can classify it into 3 forms: predominant ILD, combined ILD-PH, and predominant PIH. This can allow to better risk the stratification of the candidates for lung transplantation. And as more information about the pathologies will, the scleroderma, ILD, and PH will voluntarily emerge, maybe this cutoff can be updated. Talking about the shrinking lung syndrome is typically presented in patients with a background of relevant systemic autoimmune disease, most commonly lupus, but also in patients with scleroderma. And they presented with this dyspnea with or without chest pain. They can have had previous episodes of pleuritis, and they could have orthopnea, probably due to rheumatic weakness. The hypothesis and the cause of this syndrome are different. Maybe because of reduced diaphragmatic muscle thickness, maybe because of diaphragmatic dysfunction, maybe because of pleural inflammation, maybe because of the paralysis of the phrenic nerve. This patient should get studied very well, because diaphragmatic involvement could contraindicate the transplantation. Going to look at the extrapulmonary risk factor, we should look before transplantation. Of course, there are a lot. Starting with heart, gastrointestinal tract. We should look for antiphospholipid antibodies, which can occur in 10 to 43% of patients. And we should look at the kidney and on the vascular side, because of the renal phenomenon, which can occur in up to 95% of this patient. Going to look at the gastrointestinal problem, the major problem is esophagus. And so esophagus must be a rigorous study before transplantation. We can do barioesophagram, we can do AGDS with biopsy, we should do manometry with 24-hour impedance study. As you can see in the images, in the left side, there is a manometry with achalasia type 1, and in the right side, an achalasia type 3. So do we have to not transplant this patient? No, we need to study them, and we need to face the consequences of this dysmotility. So what can we do post-transplantation? We can give them a high-dose proton pump inhibitor therapy with treat enteral feeding for 3 months post-operatively, or we can intervene with surgical, like fundoplication. In this study from Columbia University, patient with an esophageal problem underwent fundoplication after lung transplantation, and they have a better survival and also a better freedom from chronic lung allograft dysfunction than patients who didn't. That's because aspiration and GERD are two independent risk factors for the development of chronic lung allograft dysfunction. The kidney instead is variably affected in patients with scleroderma, and up to 63% of patients will develop acute kidney insufficiency post-lung transplantation, and up to 59% of these patients will develop chronic kidney failure. That's probably because the use of the calcineurin inhibitor that are fundamental in the therapy on the immunosuppressive regimen after lung transplantation. Which kind of risk factors do we need to wait before the lung transplantation? Previous scleroderma renal crisis, the presence of RNA polymerase III antibodies, the rapidly progressive or diffuse skin involvement, and the duration of the disease. Going to the heart of the problem, in autopsy data, 50% of patients with scleroderma has cardiac involvement. But the problem is that this involvement is clinically significant only in the 10% of patients. And this is a problem. The other problem is the prognosis, because the prognosis of the pulmonary arterial hypertension in connective tissue disease is poorer than in idiopathic pulmonary arterial hypertension. In fact, in the REVEAL score, which is the estimated survival at 1 year, is 40% for patients with PIH in connective tissue disease and 68% in patients with idiopathic form. I will not discuss about PVOD as we already did. And then the other problem is that not every pulmonary hypertension is pulmonary arterial hypertension. In fact, there is there could be also heart failure with preserved ejection fraction in 27% of the patient. So what can we do? We need to do a pre-transplant screening. We need to do the CT scan, the echo Doppler cardiography, the right and the left heart catheterization. And if we notice arrhythmia, we need to do the 24 hours Holter monitoring and cardiac MRI. Cardiac MRI should be performed in all the patients in which we suspected that there is a cardiac involvement before lung transplantation, because cardiac MRI can detect myocardial fibrosis and inflammation. 75% of patients with scleroderma had at least one abnormalities in cardiac MRI, but also 43% of patients with lupus. And there is no correlation with the patient's degree of clinical symptoms. What can we help? In this work, HFPE was defined by the presence of exertional dyspnea, abnormal cardiac structure, and NT-proBNP level elevated. In this study of 155 patients studied with scleroderma, 27% and had HFpEF. And this increased the risk of dying of 3.4. And we should test all the patients with NT-proBNP, because NT-proBNP was an independent factor of worse prognosis. So if we have an NT-proBNP level elevated, we should get the patient an MRI. Going to lupus, we need to screen, as before, the presence of antiphospholipid antibodies. We need to look at the kidney and the heart, in the heart. But we should look also at the presence of thrombocytopenia, which can occur in up to 10 to 40% of patients. So if we have thrombocytopenia, an hematologic evaluation is needed. And also we should look at the neurological and psychiatric problem that can occur in up to 80% of the patient. And if we suspect something, we need to call a neurologist and then a psychiatric. And based on the neurological evaluation, we need to screen the patient with brain MRI or EEG or neurocognitive tested besides the recommendation. Rheumatoid arthritis, we need to screen at the upper airways, and particularly on the cricoarytenoid joint. because its involvement could worsen the prognosis, and it can occur in 30% of patients. We should look at the cervical spine, because its involvement is common in patients with rheumatoid arthritis, and increase the risk for stabilization and spinal cord compression, and also because severe erosive arthropathy can impact the pre and post-transplantation rehabilitation, and so the outcomes of the patient. And it can occur in 25 to 34% of patients. And then we should screen them for the sensory motor neuropathy, which can also affect their possibility to rehabilitate. Going to the polymyositis, dermatomyositis, we should look, as usual, at the heart, and then we should test them for cancer. Instead, in fact, in patients, in particular in patients with dermatomyositis, the cancer-associated risk is very elevated. It's up to 70%. We should look in particular in patients male sex, older than 45, and the patient who have a rapid onset of myositis. We should screen them for dysphagia, because the weakness of the muscle in the upper third of the esophagus can lead to dysphagia, and this could be a contraindication for lung transplantation. But most important, we should look at the diaphragm, because the diaphragm is involved in almost half the patient, and the diaphragmatic involvement could contraindicate the transplantation. Then going to ANCA-associated vasculitis, which are a more rare indication to transplantation, which only the patient with the UIP should undergo lung transplantation. But the big problem is the disease relapse that can occur in a variable number of patients. We have some data on the kidney and on the heart, not so much on the lung transplantation. But the lung disease and the presence of anti-PR3 antibodies are a risk factor for the relapse of the disease. We should look at the neurological problem and involvement as the kidney involvement, and also on the upper airways involvement, because patients with vasculitis could have affected the sinus and the upper airways. At last but not least, the Sjögren's syndrome. I couldn't put all the manifestation extrapulmonary, because there are a lot, and I will need them like 2 to 3 slides. But I will put the contraindication, which are dysphagia, that can. And so, what contraindicated lung transplantation in Sjögren is a penetration aspiration scale of 4 or more, and then B-cell lymphoma, which can occur in patients with Sjögren's syndrome. And patient who had B-cell lymphoma could be listed for lung transplantation if they have free from disease time at least 2 years for patient with MALT, or at least 5 years for patient with diffuse B-cell lymphoma. So timing is essential, because of all the possible extrapulmonary risk factors that we need to investigate before listing the patient, because we need to do a therapeutic optimization before transplantation, and because, as we've seen before, the rapid and unpredictable evolution that this interstitial lung disease could have in some CTD. So early referral to lung transplant center of potential candidate is mandatory. And this is very remarked on the consensus document. Pre-transplant treatment strategies. What can we do? We should avoid significant extrapulmonary toxicity, and we should avoid over-immunosuppression, not just because of the infection complication and colonization after lung transplantation, but also because we need to maximize the survival during the waiting time and on the waiting list. So in conclusion, and I quoted what the consensus said, lung transplantation in CTD requires a comprehensive knowledge of the extrapulmonary manifestation. The evaluation and the management of the extrapulmonary manifestation are critical to the care, and the intervention need to be done early and later after transplantation. In addition, in this patient, this patient could be on a complex biological immunosuppressive regimen before transplantation. So we need to take into account when we choose a drug, the risk-benefit analysis for these patients. And therefore, a multidisciplinary team must be involved early in the management of this patient and throughout all the subsequent phases of transplantation. And with this, I thank you for your attention.
Questions from the audience? No, because we discussed that these two lectures are so different that we can do. Thank you. Sorry, Dr. Zanframundo. If is not there any questions from the audience, maybe that I can start. We know that there are patients with rheumatic diseases, but all the interstitial lung disease can exacerbate or can go to a very rapid progression. How do you deal with these patients in relation to lung transplantation? Because clinically it's very difficult.
It's very difficult for us as well. We try to screen them before if they are our patient. We have a multidisciplinary clinic with a rheumatologist and also with cardiologists who are involved. It's difficult because we need to decide ECMO or non-ECMO where they get worse, because you know that when you put patients on ECMO, it's not forever. It's a limited time. So we need to do.
What does it mean, a limited time?
Because when you put a patient on ECMO, in 3 weeks you have to decide because of the complication related to ECMO, infectious complication, blood problem with coagulation. So we need to decide when the patient, briefly, we need to screen him or her. If lung transplant is available, we need to look at the possibly extrapulmonary manifestation. We need to look at the age because age is a problem. In consensus now, maybe until 70, but for urgentized patient, the age is lower, 50 years old. So we need to, it's not so easy. When they get a rapid worsening, you need to do everything in a small amount of time.
If I may, I would have another question. You touched a very interesting case, which is the occurrence of lung involvement in the framework of lupus erythematosus systemic. What are the most frequent type of lung involvement? Because in my personal and poor experience, interstitial lung disease is very rare.
Yeah. We saw a very small amount of patients with interstitial lung disease in lupus, but shrinking lung syndrome could be an indication because of the recurrent pleuritis, and in fact, almost all the patients with shrinking lung syndrome have less.
So if I may, I have a quick question. Thank you very much. So this morning we were talking about the chance of screening, let's say, unexplained ILD for autoantibodies. And so what is the chance of a patient bearing UAP, IPF patterns, which happens to be positive to one autoantibody without any symptoms all along? So no CTD, no, not even probable. So just an IPF with an isolated antibody positivity. How do you handle that? Is it sort of disadvantage for the patient to have had a screen widely for autoantibodies in that case?
No, it's not. We will screen the patient for all the possible extrapulmonary manifestation that could contraindicate the lung transplantation. So it's not depends on the antibodies, but it depends on the extrapulmonary manifestation that could contraindicate to that.
More questions? If not, thank you, Dr. Brigatti. Lorenzo, sorry.
Just one observation, because it's true, we can transplant patients with connective tissue disease, but we should be careful also to continuous monitoring of patients because of the risk of relapses. We have no data, but it's possible. So we should really be careful. So also to monitoring should be performed in a multidisciplinary unit. That is the basis for the well-being of these patients.
That's what we do.
Okay, thank you. Thank you again. I am very happy to introduce Giovanni Zanframunt, Assistant Professor of Rheumatology at the University of Pavia. This topic is a very important topic in my opinion, because we need this instrument to put our patient in clinical trial, but also we need this instrument and to discuss about this topic from a clinical point of view. Giovanni has a role in this field of research, so I'm very happy to hear your last advice on this topic. Thank you.
Thank you very much for the introduction, and good evening, everyone. So in my presentation today, I will try to give some guidance on how we classify patients with myositis. And to do so, I will do a quick roundup of all the available classification criteria for myositis, trying to underline the strength and weakness of each one of them. And we need necessarily to start from the beginning, which is 1975, with the publication of Bowen and Peter criteria. These are very well-known and very widely used criteria that allow to classify the patient as having polymyositis and dermatomyositis, starting from a number of variables that encompass muscle and skin domain of disease. But right after the publication of these criteria, as soon as 1991, the need of more clinical entities emerged to describe the whole clinical spectrum of myositis. And in 1991, we got the first description of myositis associated with connective tissue disease, the antisynthetase syndrome, and of IBM. And then also other clinical entities added over time, like amyopathic dermatomyositis, immune-mediated necrotizing myopathy, and overlap myositis. But if we look at the classification criteria, the most widely used from 1975 to 2003, we see that there are not so many changes in these classification criteria, since most of them just allow to classify the patient as having polymyositis or dermatomyositis, and sometimes IBM. And all of them focus mostly on muscle and skin domain, skin involvement of the disease, and the role of autoantibodies very limited in this classification criteria. We need to wait 2004 to see more clinical entities to be added to the classification criteria, and these are the ENMC criteria, in which were described 4 new clinical entities: the possible dermatomyositis, sign dermatitis, the amyopathic dermatomyositis, non-specific myositis, and immune-mediated necrotizing myopathy. But with the exception of amyopathic dermatomyositis, as you can see, the other 3 clinical entities did not differ so much one another, except for the criteria regarding the muscle biopsy. And we should also notice that autoantibodies are included in these criteria, but they are not used to decide in which category you put your patient in. So in 2005, we also had the description of this new clinical entity called overlap myositis, which is defined as the presence of myositis with at least one clinical overlap feature, which are basically clinical manifestation of other rheumatic diseases, or the presence of an overlap autoantibody, which are basically described as the antisynthetase antibody or scleroderma-associated autoantibodies, or those autoantibodies that are now known as myositis-associated. And in this very study, the authors also reclassified 100 patients that were previously classified following the original Bowen and Peter criteria. And as you can see, the novel classification criteria redefined the classification of many patients, especially of polymyositis patients, which were very few after the application of the novel classification criteria, and the overlap myositis was the most prevalent form of myositis in these patients. And it's not a case that in those same years, some authors start to question the very diagnosis of polymyositis. And some authors said that the prevalence of polymyositis could be around 2% of all the forms of myositis. And other authors even questioned the very existence of polymyositis. And at the end, one author proposed an approach that is an adaptive reasoning when diagnosing a patient with polymyositis. Polymyositis says that the same reason that we make when we recognize an animal as a duck, but we cannot see that, but we see that it walks like a duck, eats like a duck, and walks like a duck, and then it should be a duck. So with this in mind, there were a very high need of up-to-date classification criteria that could be more useful in classification, in classificating the patient, given the heterogeneity of the myositis spectrum disorder. And in this context, we got the EULAR ACR 2017 classification criteria, which all of you probably know, and they are made of 16 clinical variables that allow to classify patients as having polymyositis or immune-mediated necrotizing myopathy, IBM, amyopathic dermatomyositis, and juvenile dermatomyositis. But as you can see here, among the clinical variables that were and variables that were taken into account, most of them were still focused on muscle and skin involvement of disease. There is no other organ domain in these criteria. So the only MSA that was considered for the classification was anti-Jo1. So where are the other MSAs? Are muscle and skin involvement enough to classify these patients? And where did the overlap myositis end up? And so it looks like not much changed since Bohan and Peter criteria from 1975 to 2017, because we still got criteria that are based on muscle and skin, and that's it. And autoantibodies have a very small role in classifying these patients. So the performance of the EULAR ACR criteria was also tested in particular subsets of patients. And I want you to focus on anti-MDA5 patients, in which 21% of these patients were misclassified by the EULAR ACR criteria, mostly because the majority of these patients had ILD and not an overt muscle involvement. And the same can be said in this other study for patients with anti-PL12 patients, anti-PL12 antibodies and anti-HMGCR autoantibodies. But why is it so important to consider also other organ domains? This is a meta-analysis that tell us that the overall prevalence of ILD in patients with myositis is 41%, and it goes up in patients with specific autoantibodies to 88% and 77%. And these are values, especially notice the anti-MDA5 and the anti-synthetase autoantibodies. And another reason is that, as you already saw this morning, this same image from a study of Professor Cavagna, interstitial lung disease, but also arthritis, and the combination of arthritis and interstitial lung disease, which means a disease that has no muscle involvement, is not so infrequent in patients with anti-synthetase syndrome. this is true at the onset of the disease, but it is also true at the last follow-up. As you can see, ILD, isolated ILD is still very prevalent in patients with anti-PL12 autoantibodies. So a more rational approach was proposed in this study here that proposed to classify the patients following the serology of myositis, and also proposed to consider clinical entities such as antisynthetase syndrome as independent clinical entity, but basically it proposed a division in 4 big categories: overlap myositis, dermatomyositis, immune-mediated necrotizing myopathies, and inclusion body myositis. And this is another study that used a different approach to try to find a more efficacious way to classify the patient. And in this study, a hierarchical analysis was used to classify 260 patients with myositis, taking into account 47 clinical variables. And 4 clusters of disease were found. The first one was mostly regarded mostly patients with IBM, so patients with no myositis-specific antibodies and with a disease that is mostly limited to the muscle. The second cluster is the immune-mediated necrotizing myopathy or polymyositis, and in this cluster, we saw many patients with anti-HMGCR or anti-SRP autoantibodies. Cluster 3 is basically dermatomyositis with anti-MI2, anti-MD5, anti-TIF1 gamma. And cluster 4 is a disease characterized by interstitial lung disease, skin lesion, mechanic hands in particular, and is 19% of these patients were diagnosed as having antisynthetase syndrome. But going on with other classification criteria that were released during the years, these are the ENMC criteria for necrotizing myopathy of 2016, in which it was proposed to give the name of the autoantibody to the subtype of necrotizing myopathy. And so they recognize an anti-HMGCR myopathy, anti-SRP myopathy, or autoantibody negative necrotizing myopathy. And the same approach was used in the paper about the dermatomyositis criteria, in which they suggest to give a subclassification of the diagnosis according to the autoantibody present in the patients. And this approach that seems to be, very appealing. There is a reason why it looks so appealing, and this study tells that when you classify the patient according to the MSA that is present, you see how good the patient migrate in the same area of the graph. These are all patients with antisynthetase antibodies that all migrate to the right upper side of the graph. These are all patients with dermatomyositis-related autoantibodies that all migrate to the down left part of the graph. And these are patients with antibodies related to the necrotizing myopathy that all migrate to the down right part of the graph. While when you do the same operation with by applying the classification, the EULAR-ACR criteria, you see how chaotic the graph is and how much overlap there is between the different forms of myositis. So basically, applying the known criteria is like doing what we see in this figure. We have a patient with his autoantibodies clinical manifestation, and we try to fit this patient in a determinate subset of disease. And sometimes the patients may fit in that classification, but we are still missing what the reality is. So the proposal is to expand the clinical spectrum of myositis. This is just a proposal of what we know about the different clinical phenotypes of idiopathic inflammatory myopathies. And an effort is being made in this direction with the CLASS project, which is a project aimed at developing the classification criteria for antisynthetase syndrome, led by University of Pavia and University of Pittsburgh. And it is made by a data-driven part and an expert-driven part. And as you can see, these are the variables that we are taking into account to classify the patient as having antisynthetase syndrome or not. And myositis is just one of them. Skin manifestations are right here, and all these other manifestations are lung, are systemic manifestation. It's the whole spectrum of possible clinical manifestation of these patients. So a brief overview of the univariate analysis. As you can see here, circling in red, the manifestation with the higher odds ratio, so the higher capability of discriminate which patient has antisynthetase or has not antisynthetase syndrome, are right those manifestations that are not actually into the classification criteria, like mechanic sense or Eicher's fit, anti-Row 52. Well, this is muscle weakness and diffuse myalgia, which have 1.2 and 1.3. And as you can see, compared, for example, to ILD is a very low odds ratio. ILD has an odds ratio of 8.5. And this is, about the data-driven part. But if we look at the experts' proposed criteria, we saw the same thing, basically. Extramuscular and extracutaneous involvement has a very high weight in determining the classification of patients as having antisynthetase syndrome, 13%. The myositis, the biopsy evidence of myositis has a lower probability of making the classification. And as you can see, of course, the autoantibody testing has the highest values in determining the classification of these patients. So in conclusion, myositis are a group of heterogeneous disease with a great number of possible clinical manifestations. And the older classification criteria mainly focus on muscle and skin disease and recognize only few clinical entities like polymyositis, dermatomyositis, and IBM. And in the course of the time, as new MSAs were described, the need of codified new clinical entities has risen. But the most recent, the most updated criteria that we have, we saw that they have a suboptimal performance in classify the patients with myositis, especially in those formed with non-predominantly muscular or cutaneous expression. And the classification of myositis according to the serology of the patients seems to be more discriminative in classify the patients in the right way. And it still may be not enough, since new studies are raising, are providing more evidence about proteomics and other more detailed way to classify these patients. Thank you for your attention.
Thank you. Thank you very much. Is there any question, Lorenzo, please?
I think that we have again a lot of work, and we need, I think, not the univariate, but also the multivariate analysis for sure. Carlo, can you have any update about multivariate analysis of the CLASS project? Can you refer to us any news?
Nothing unexpected, because we need a strong methodology sometimes to confirm something that we already know. So in this spectrum of disease, such as antisynthetase syndrome, we have a typical the typical concept of antibody driven classification and a subclassification by clinical features. So I would like to ask Giovanni, in general, in inflammatory myopathies, do you think that this is the right approach, starting from, of course, in patient with a suspected condition, to stratify patient by antibodies and then to classify by the type of clinical involvement, or is a mixture?
Yeah, well, I think that autoantibody is the best that we have right now to classify the patient and to be as more specific as possible in saying what kind of disease these patients have. I'm not sure that it will always be the same, as I said at the end of presentation, because more evidence is raising about proteomics and genomics and artificial intelligence approach to discriminate other variables that can help us to classify the patient in a very specific group of disease. But autoantibodies is the best we have right now, and it's the most available tool that we have to be as more specific as possible.
Any other question? I have one more question, if you can. Among all these myositis associated or specific antibodies, are there some of them which are biomarkers of disease activity beyond MDA5, which is used to monitor the response or to treatment? Or the other antibodies useful to monitor?
Amongst the myositis specific antibodies? Yeah, that's the point. In myositis specific antibodies, we talked yesterday about the levels of anti-MDA5 that can be related to the disease activity. But if we extend to the myositis associated antibodies, anti-Rho52 seems to have a role in predicting the severity of interstitial lung disease, even if we have conflicting data in literature right now. And I'm not aware of other autoantibodies that can mark disease activity in any way. Actually.
Thank you. Okay, so I think we can thank Giovanni for this wonderful presentation again. And to close this section, and I don't know if you have something to.
Tomorrow, because as I told you, unfortunately, the last speaker is not present. So we will see tomorrow. Enjoy Pavia and enjoy your city if you are connected from another side. Thanks a lot.